a couple of special guests who will join us later. Two of our very special patients who were kind and gracious enough to agree to share their stories. And I hope that you will find some inspiration in that and confidence inspired in the team that's taking care of you. And then lastly, but not the least, we have a couple of our special partners who have partnered with us today in putting up this event. James Carroll, who's the president of the ACMP Research Foundation, and Adele Jason, who is the vice president of PMP PALS. As noted before, please don't hesitate to put your questions in the chat. And we will have a break sometime in the middle. So without any delay, we can proceed with the seminar.
Great. Thank you, Dr. Mogal. I have a few housekeeping notes and then we're going to get started. You probably all saw a note that this webinar is being recorded. So just want to make sure that you all are aware that this webinar is recorded. If you all have questions as our speakers are talking, please post them in the chat function. They will answer them as they are able during the talk, but probably after they're done, and they'll respond in the chat function itself. If we have time at the end, we'll address some more questions if we have time. And also one other note that if you accidentally leave this webinar for any reason, if you have computer issues or anything like that, and don't worry, you can click on the link and you can be admitted back into this webinar. So don't worry if that happens, you can get right back in. All right, so I'm going to stop sharing my screen and I'm going to turn the mic and the screen sharing over to Dr. Mogal, who is going to talk to us about the role of HIPEC in peritoneal cancers. Thank you so much.
Thank you. I'm going to try to share my screen. Is that coming across okay?
Yes. Yes, looks great.
All right, great. So in this brief talk, I just wanted to introduce the cytoreduction and HIPEC procedure. We'll talk a little bit about the common indications, how we select our patients for this type of surgery, and what should we expect in terms of outcomes, both short as well as long term. To start with the anatomy of the peritoneum, as I explained to a lot of my patients in the office setting, the abdomen, internal organs on their outer surface. So for example, the outer surface of the liver, the bowel, the colon, the surface of the uterus, rectum, bladder, they're all formed by this peritoneal layer. And when cancer reaches the peritoneum, either primarily because it arises from there or because it comes from another organ like the appendix or colon, we term it peritoneal disease. So how does peritoneal metastasis progress? So it usually starts with tumor cells from the primary tumor, like the appendix or colon, detaching from the organ of origin. And these cells then transport through the normal pathways that the peritoneal fluid takes into different parts of the peritoneal membrane. When these cells eventually detach and attach to a distant site of the peritoneum, so a site away from where the organ is located, it forms peritoneal disease. The tumor cells invade into the space below the peritoneum, so they almost take root, cells that form multiple tumors. And why this is important is because if this is not treated, then almost always patients, unfortunately, succumb to this particular process from their disease. Treatment of these tumors is challenging and often requires patients to be referred to specialized centers that deal with patients that have peritoneal disease and have programs to deal with it. Just a brief introduction of how bad this problem is. This is just a quick reminder that peritoneal disease, especially in patients with colon cancer, for example, is notorious in terms of its prognosis. Most patients with isolated peritoneal disease will do much worse than patients with say, liver metastasis or lung metastasis from colon cancer. And this persists across all types of chemotherapy regimens. And therefore, while chemotherapy has advanced significantly in the last several decades, it is unfortunately not the ideal treatment to give patients a prolonged period of time with quality of life. And the only time we can really prolong patients' life is with the combination of chemotherapy as well as surgical treatments like HIPEC. So what does cytoreduction involve? So on the left, you'll see basically a picture from one of our patients who had significant amount of peritoneal disease in their abdominal cavity. As you can see, there's multiple bumps and tumors throughout the entire peritoneum, and we have basically stripped the entire lining from the abdominal wall. On the right, you see a picture of bulky implants within the omentum that are stuck to the bowel and surrounding organs, which we're trying to remove. So cytoreduction basically involves removal of all the different tumors within the abdominal cavity. And this may involve not only stripping the lining of the abdomen or the peritoneum, but also removing certain organs that are involved by the tumor. Eventually, this process can take anywhere from 6 to 10 hours because it is so extensive. And following that, we administer the heated chemobath or HIPEC. When we proceed in the operating room to treat patients with peritoneal cancer, we score their disease burden or the amount of tumor they have in the peritoneum based on a generic score called the Peritoneal Cancer Index. And this is important because the PCI index is known to independently predict how well patients will do after surgery. How we do that is dividing the abdomen into multiple different regions, as well as the small bowel into 4 different regions. And then depending on the amount of tumor we have in each of those different regions, we classify the PCI score anywhere between 0 and 3 in each of those regions. And so eventually patients can either have a PCI of 0, where there's absolutely no tumor, or they can have a PCI of 39, which means every single quadrant in their abdomen is completely caked in tumor, and there's no area of their abdomen that's free of tumor. Most patients live somewhere in the middle. But what's not only important is the PCI, but also most importantly is the amount of tumor we leave behind after we have completed the cytoreduction. And this is a measurement of the residual disease. So our aim when we do cytoreductions on patients with appendix, ovarian, colon, or other types of cancers is to remove all the visible tumors such that we leave no visible tumor behind. And rarely, if that's not possible, then we want to at least make sure that the tumor nodules left behind are less than 2.5 millimeters, because that is considered the threshold at which the HIPEC can actually penetrate the tumor nodules. So our goal is to remove all of this disease. And many of you have heard me say this, that when we do these procedures, what we want to make sure is that we're not cherry picking tumors, but we're actually removing every single bit of disease. And so what do we do in the HIPEC part of the procedure? So once we have finished the cytoreduction, we put special catheters in the patient's abdomen, and then we connect these catheters to a special circuit pump called a perfusion circuit pump. And then the abdomen is temporarily closed so that the chemotherapy can then be installed within the abdomen. And that can circulate anywhere between 60 to 90 minutes, depending on the drug that we're using. And the temperature is typically around 43 degrees centigrade or about 108 Fahrenheit. And we maintain a certain amount of flow so that the chemotherapy solution does not stagnate in any particular part of the abdomen. And sometimes we have to gently agitate the abdomen in order to facilitate that. Once the chemotherapy is over, we wash out the abdomen really well, and then we close the patients up. And the rationale for doing this type of chemotherapy is that when we install chemotherapy directly into the abdomen, we can achieve very high doses of this drug within the abdomen, which we would not be able to achieve if we were to give the same medication and try to achieve the same dose if we IV. So the HIPEC treatment exploits what we call the plasma peritoneal barrier. So there's a natural barrier between the peritoneal cavity and the bloodstream, where if we install chemotherapy in the peritoneum, it stays confined to the peritoneum, and minimum amount of that fluid or chemotherapeutic drug gets absorbed into the circulation. And thereby, we can achieve maximum effect in the peritoneum to kill cancer cells and minimum absorption in the circulation so as to minimize side effects after surgery. And we can achieve drug 25 to 1,000 times what we would normally able to achieve. The hyperthermia, or the heat itself, potentiates toxicity because heat in itself it kills cancer cells, and the heat also synergizes with the chemotherapy and helps it penetrate the cells better. And we have a host of chemotherapeutic agents that we can typically avail of. The most commonly used agents are the ones that are what we call hydrophilic, which means they don't really dissolve and diffuse through the peritoneal membrane. They have a high molecular weight, which means they stay in the peritoneal cavity, and they synergize well with heat, which means they act in concert with heat so that their effect is even more magnified. Cisplatin and mitomycin C are some of the commonest agents we use in the peritoneum, depending on the type of cancer we're treating. So the common indications for which we do this operation are appendiceal tumors, and these include both appendiceal adenocarcinoma as well as pseudomyxoma peritonei, which forms from mucinous appendiceal neoplasms, colon cancer, peritoneal mesothelioma, sometimes in gastric cancer, and more recently with patients that have ovarian cancer. Some of the standard criteria that we have to look to when we discuss with patients their ability to undergo the surgery. One is that they should be able to tolerate an extensive surgery and recovery. And oftentimes patients are concerned because of their age that they won't be able to tolerate it. But there is a concept in surgical care called frailty. And there are patients, for example, who are well into their 70s, but who are otherwise extremely fit, who can tolerate surgeries well, versus other patients who are in their 40s or 50s who have major medical problems who may not be able to tolerate surgery. So while age is important, it is not the be all and end all in terms of how we assess. It's their physical and overall functional performance that goes into making that decision. The second thing is we want to select patients with what we call favorable tumor biology. And this is a relatively nuanced topic and relatively nuanced aspect to understand. But in general, every patient's tumor has a unique stamp or signature in terms of how it's going to behave, in terms of how aggressive or less aggressive it's going to be. We don't have ways to directly measure that, but we have indirect ways in which we can assess that. And so one of the things we can assess is how long has it been from the patient's original cancer diagnosis to the time they develop peritoneal disease. The longer that time interval, the better the biology. Similarly, what is their response to chemotherapy? In terms of the tumor shrinking on CAT scan or MRI, in terms of their tumor markers, which are their blood cancer marker levels going down, and also how they feel overall on chemotherapy. And then there are other certain tumor genetic profile genes, for example, KRAS, NRAS, BRAF, that can, in some situations, predict what the patient's biology is going to be. And we don't want to offer these surgeries to patients with really poor tumor biology because, unfortunately, no matter how much we do in terms of surgical care, if their biology itself is aggressive, then their surgery is not likely to be successful. And so then we would have put them through a huge operation with all its attendant side effects with minimal benefit. And the last thing we have to take into consideration, which is arguably one of the most important criteria, is can we achieve a complete cytoreduction in the OR, which means can we remove all the tumors physically from the abdominal cavity when we do this operation? And again, this one is relatively challenging to assess, but we use a combination of different factors. For example, what does the disease look like on CT or MRI? And then many a times, and some of you have experienced this, is we do a laparoscopy a few weeks before the actual HIPEC operation to actually get a real-time assessment of how much peritoneal disease there is. When it comes to preoperative planning, there are several different facets that have to kind of work together. And that's why we have a wonderful multidisciplinary team that works with us to help achieve this. I always counsel patients about all the potential side effects that can happen, which can happen in up to 40% of patients. Thankfully, the mortality from this operation has significantly declined since the operation was first devised, and now less than 1% of patients typically don't make it out from surgery. Good performance status, like we talked about earlier, which means otherwise very well functioning and healthy. We usually have recent imaging for patients within a month so that we can assess their response to treatment, as well as make sure that the cancer has not spread to other parts of the body. All of our patients are assessed by our multidisciplinary team, which includes a thorough assessment from a nutrition standpoint, physical therapy standpoint. Some of our patients have to undergo ostomy, teaching, and marking, and then sometimes we involve social work if there are issues with care coordination. We always strive to minimize or optimize the patient's medical conditions. So many a times they meet with our medical doctors as well as anesthesia team to optimize some of these things. And then we have to wait for an appropriate amount of time before we subject patients to surgery when they're on chemotherapy. So usually anywhere between 4 or 6 weeks, depending on what agents they're on. And then, like we discussed prior, sometimes we need a laparoscopy in order to real-time assess whether a cytoreduction or complete cytoreduction is going to be possible. On an average, most patients spend about 7 to 10 days in the hospital. Our average at UW is approximately 8 days. There is very rarely the need for the ICU, especially in older patients or patients with significant medical issues. The recovery at home, as you've heard me say to a lot of you, is anywhere from 8 to 12 weeks, sometimes even longer, just because of all the different side effects that can happen in the first few weeks after surgery. And most of our patients follow very closely with us almost every week after they're discharged from the hospital until we know that they're over the acute hump. Sometimes patient will need more chemotherapy after surgery. And then in terms of long-term follow-up, we have different strategies of how we follow patients lifelong. Some of the commonest side effects from this operation include bleeding, infection, pain and discomfort, which usually takes a while to get better. Fatigue, insomnia is a big problem that a lot of patients face, and we don't know exactly why that is. Many times we are worried about forming blood clots, so we put patients on blood thinners because of the extent of the surgery. And then rarely we have complications like an anastomotic leak or a leak from where the bowel connections have been made in patients with HIPEC that can lead to complications. Sometimes there can be short or long-term problems with bowel, like constipation or diarrhea. And then one of the problems that many patients struggle significantly with is the ability to maintain their oral intake of fluids as well as calories that then eventually require us to use supplemental ways to feed them. A brief overview of the different types of cancers that we treat with Hypex. So pseudomyxoma peritonei is basically the accumulation of mucin or gelatinous substance in the peritoneum from certain types of what we call mucinous appendix cancers. And when the tumor spreads beyond the site of the appendix in the right lower abdomen into other parts of the abdomen, that's when we call it pseudomyxoma. No matter what the pathologist sees under the microscope, when we have this type of a tumor, it's always considered stage 4 disease. And whenever there is a discrepancy in what the appendix shows versus what we see in the peritoneum, we always use the peritoneum to guide our treatments. Some of you may have heard me talk about this. Very critical in terms of how we treat patients with appendix cancer is their actual pathology. But to summarize it, we talk about patients having either low-grade disease or high-grade disease, and then high-grade disease with signature cell. And this is important to know because prognosis significantly depends on this, and even treatment depends on this. For example, in low-grade patients, we seldom employ systemic therapy or chemotherapy, whereas in high-grade patients, we almost always do chemotherapy before we do surgery. As you can see here, these different lines, this is basically what we call a survival plot. And the higher you are on the plot and the longer you are on the plot, the better the survival. As you can see in patients with pseudomyxoma peritonei that have very few cancer cells in the peritoneal lining, but only mucin, they tend to do the best, as in the red line. Whereas unfortunately, patients who have what we call poorly differentiated cancer with signet ring cell, the one in the orange graph, tend to do the worst. Most other patients stay somewhere in the middle. And sometimes patients and even providers ask, is there a limit to the amount of tumor that we have in the abdomen where you can say, okay, we set a cut point and then we can't do any more? And the answer to that is largely unknown, but there have been a few studies that have looked at that. For example, in the graph to the left, you see this uses a different scoring system of the amount of residual disease left behind. It uses the R scoring system. And it shows that in patients with these low-grade appendix tumors, even if we're not able to achieve a complete cytoreduction, but we can get the bulk of the tumor out, we still have benefit in terms of overall survival. However, in high-grade patients, what is really critical is that we need to remove every bit of tumor out because only patients with these CC0 resections tend to do well. Those patients in whom we leave any residual disease behind won't do well. And in patients who we can remove significant amount of disease, even with stage 4 cancer, on an average, most patients survive 5 years, but that's average. Obviously, some are longer and some are shorter. There are some instances in which we really can't do a whole lot when we go into the abdominal cavity, and we call them somewhat what we call contraindications to surgery. So for example, if they have extremely high PCI or peritoneal cancer index where the entire small bowel is involved, our hands are unfortunately tied and we can't do a whole lot. Similarly, if they have extensive disease at what we call the porta hepatis, which is the area that supplies blood and takes bile away from the liver, many a times we can't do a whole lot. If they have extensive retroperitoneal disease, which means now the disease is growing through the peritoneal cavity into the behind or the back side of the abdomen where the kidneys and the ureters and other blood vessels exist, usually we can't do a whole lot. And then rarely in patients with liver tumors, we can still offer HIPEC as long as the number of tumors inside the liver are few and easily removable at the time of surgery. In colon cancer, I won't go into some details, but this is one of the earliest trials that looked at the efficacy of HIPEC, cytoreduction in HIPEC, in comparison to chemotherapy alone for patients with colon cancer. And you can see from this graph that those patients that had HIPEC did better than those patients that did not get HIPEC. And we have seen this play out in several large-scale studies from high-volume centers where in comparison to the standard of care chemotherapy, patients that underwent cytoreduction in HIPEC did much better overall long-term. Some of these studies have been criticized because they were done at the time when our modern chemotherapy regimens that we employ today were not available. And so a lot of people who treat peritoneal cancers, especially surgeons, have been interested in this question of which aspect of the treatment in cytoreduction and HIPEC provides maximal benefit. Is it the cytoreduction or is it the cytoreduction with HIPEC? And this is one of the trials that is frequently referenced by a lot of our patients for colon cancer. It's called the PRODIGE 7 trial that came out of Europe and was published recently. In this study, patients who underwent chemotherapy first and then were taken to the operating room to undergo cytoreduction were then randomized, which means they were randomly allocated to one of two arms, either having surgery with cytoreduction alone or surgery with cytoreduction and HIPEC. And what they noted in the grand scheme of things is that there is no difference between adding the HIPEC to the cytoreduction or doing cytoreduction alone. Most patients did quite well in the overall sample of patients, and the average survival for these patients was about 41 months. The amount of time patients survived without developing any recurrence whatsoever was about approximately 12 months. But when you looked at different groups within this population of patients, those patients who had intermediate scores of disease burden did benefit from addition of HIPEC. And so the question is, do we use this data as dogma within the United States and treat all patients with colon cancer accordingly? For example, should we be avoiding HIPEC in all these patients? And the answer to that, again, is largely unknown. In the US, one of the things that we noted with this trial was that the way the trial was designed was not very much in keeping with what we know with peritoneal disease. For example, they assumed that cytoreduction would only lead to a 30-month survival benefit. However, in their own data, they noted it was well over 40 months. Secondly, they overestimated the relative benefit of HIPEC over cytoreduction alone. And so having an 18-month benefit, we know from most groups that treat peritoneal disease is an overestimation. Secondly, they used a drug called oxaliplatin, which is given IV in a lot of patients that have colon cancer prior to surgery. And this drug is interesting in that it doesn't really act very well when you subject the peritoneum to this drug for very short duration of time and at high doses. All it does is it increases the side effects because of the higher dosing, but decreases the efficacy. Many times these patients who did undergo oxaliplatin chemotherapy in the abdomen also had oxaliplatin preoperatively or before their surgery. And we know that some of these patients had significant resistance to that medication. And so using oxaliplatin was not necessarily the best idea. And lastly, there were some patients who crossed over from the cytoreduction arm to the HIPEC arm. And while they use some fancy statistics to justify how the outcomes did not differ, it's hard to know because that was not the way the trial was meant to be. So we don't use the protege data as gospel here. We usually typically tend to look at individual patients with colon cancer and see if they're going to eventually benefit from HIPEC before we say yes or no to the addition of HIPEC in addition to chemotherapy, cytoreduction. So as you can see, there's a definitive role of patients that have metastatic appendix, colon, mesothelioma, and ovarian cancer with HIPEC. There's excellent long-term outcomes in properly selected patients as long as their tumor biology is somewhat favorable. It is important to understand this disease process and to have patients treated at peritoneal malignancy centers that have teams established that are vested in the care of our patients. And with multi-D teams and high volume experience, we only can improve our outcomes in the future. And with that, I will hand over the deck to Dr. Cohen. So I'm going to quickly introduce Dr. Cohen here. Dr. Cohen is Associate Professor of Medicine at UWMC and Associate Professor of Research at Fred Hutchinson Cancer Center. She co-leads the HIPEC Multidisciplinary Clinic with us at SCCA and has been an incredible partner in moving this program forward. So without much delay, I'm going to have Dr. Cohen start with her part.
Thank you so much, and welcome everybody. Good morning. It's a pleasure to be able to speak with you all in this format. Of course, we wish we were in person, but we're glad to see everyone here today. I'd like to remind everyone on the panel to take a look at the chat from time to time. There have been some questions that have already come up, and we encourage everybody to ask questions along the way, and we'll be keeping an eye on those. So I'm now going to be speaking about the role of systemic treatment in patients with peritoneal cancers and sort of go hand in hand with what Dr. Mogal just talked about. So first of all, we have to think about why would we ever use systemic therapy? If we're calling this a local problem, why would you want to use a systemic therapy? So when you think about a local therapy in cancer, this is a treatment delivered directly to one body part or organ, or in this case, region of the body, with the goal of treating only that area. It's great because it's targeted and it can really work for when there's limited spread of a cancer, like when you find the cancer in the initial state and it hasn't spread to other organs. And so you can treat with curative intent, or we can use it in what we would call palliation, where you have symptoms from a specific area. And so you're not going to take out all of the cancer, but you might want to take out that one area or radiate that one area. It's a unique situation like we have here, where we think we could actually surgically remove all parts of the cancer. Because it is localized, the side effects typically are localized to the region of the area of treatment, but it only will treat the area within whatever you target, so nothing outside, which means that when you have other cancer in other locations, those are not getting any treatment during that time. On the other hand, on our right column, we have why would we ever do systemic therapy? So this is a treatment often intravenous, sometimes oral, with the intention of going everywhere in the body, typically through the bloodstream. It is system-wide, and so we can use it in a number of indications, whether it's to shrink the cancer burden in the preoperative state, control the growth of cancer for metastatic disease, or perhaps reduce the risk of recurrence after someone's had surgery. The side effects may be more global and may not be necessarily have anything to do with the area where the cancer is located, depending on off-target effects. And the advantage of this is you can treat everything you see on the scans that's radiographically visible or visible on scans, but it also can treat micrometastatic disease or cancer that's too small to see. So for the purposes of this talk, since we're thinking about peritoneal cancer, we're going to think about when to use chemotherapy, preoperative, postoperative, and how do we address that micrometastatic disease. So for those of you that have familiarity with lower GI cancers, you'll have heard some of these acronyms, but just to catch everybody up, we have 5-FU or capecitabine, which is our backbone drug of peritoneal cancers that's from a lower GI source. I should note that I'm not really going to speak about mesothelioma in this talk, and of course, I'm not going to speak about gynecologic cancer, since Dr. Goff will do a good job of that next. We can combine that with oxaliplatin, we call that FOLFOX. We can combine it with irinotecan, we call it FOLFIRI. We can do all three, and we call that FOLFOXIRI or FOLFIRINOX. If we need to, we can omit the 5-FU, call that IROX. And then we can add targeted therapy like bevacizumab, which affects blood vessel growth formation, or the EGFR inhibitors, panitumumab or cetuximab. But we know not to add both because that caused harm. And then after failure of these drugs, we have a couple of other FDA-approved drugs, regorafenib and trifluridine and tapiracil, which unfortunately have very limited clinical benefit. But what we have seen in colorectal cancer over the years is that we've seen an improvement in median overall survival, so the 50-50 mark of how long patients do, which improved to about 30 months now. And we attribute some of that to increased availability of new drugs. Of course, some of that also has to do with improved surgical techniques and other localized therapies, but some of it is from the increase in drug therapies that are available. And you already saw this with Dr. Mogal, and this just speaks to the fact that we don't have that much data about peritoneal cancers because it's more limited. So we all go back to one of these original studies, which was a study looking at patients and their location of their metastasis and how they did. And as he described, this is our survival curve. So at the left here, you start out at 100% of patients are alive when they're enrolled in the study. And then if a patient passes away from any cause, whether it's cancer or otherwise, the numbers drop down. And so what we look at often is this 50-50 mark. So that's the line I drew here. And you'll see in purple are the patients with cancer that's just in the peritoneum, hasn't spread to anywhere else. And they do a little bit better since the line is higher up than the ones in red, where we see patients have peritoneal disease and other sites. So we think that there is a unique situation for patients with isolated peritoneal disease where they may do better and again gives more opportunities. The dashed line here though is because these statistics are nowhere near that 30-month survival that I just said we're seeing. So we know that patients with peritoneal disease do worse than isolated to the liver, let's say, but these statistics still are less than we would expect with modern chemotherapy regimens. So we can learn some from this, but not be able to get all of the information. So when we use chemotherapy for peritoneal disease, again, we could just say this is a cancer that has metastasized from the original location. That's concerning to us. Therefore, we need to give indefinite systemic therapy, chemotherapy to try to control the cancer. In that mentality, we're not trying to cure or get rid of the cancer, we're trying to control it. So trying to prolong survival and maintain good quality of life. But if a patient is desiring an attempt at surgery and we think is a good surgical candidate, then we want to give as aggressive therapy as possible prior to surgery because we want to position that person to be in as good of shape as possible when Dr. Mogal shows up to do the surgery. So again, we're going to try to decrease the tumor burden, so have less cancer overall. We want to shrink or control tumors, even the ones that are too small to see on imaging. And as you might have heard from your own experience or what you've been aware of is that even if we get the best imaging, a CT, a PET scan, an MRI, we still can miss peritoneal disease. So we say that what's seen on scans is the minimum that a patient may have, but they may have much more, especially if it's small. So we're going to try to get rid of as much as we can. And then again, we always want to try to get rid of what we can't see, so micrometastatic disease, because the last thing we want is to go through chemo, surgery, and have someone's cancer come back if we had a potential to get rid of it when it was very small. So we are using the same chemotherapy regimen for a couple of different purposes. So putting this in another way, so if someone has a metastatic colorectal cancer, let's say, our standard approach is just to do different chemotherapy regimens, FOLFOX, FOLFIRI, all in succession. And when we run out of regimens where we can use 5-FU, then we're going to think about clinical trials or some of those other oral therapies that we said only work okay. And this is one way to do things. But a more aggressive treatment regimen would be to go in with this plan of doing surgery. In that case, we call the chemotherapy neoadjuvant or prior to surgery. And we do that for 4 to 6 months, trying to give the most aggressive regimen possible with the plan of doing the cytoreductive surgery and Hypex following. In this plan, we are going to follow our progress with scans every 2 to 3 months to make sure that nothing is getting worse. So again, if everything completely goes away on scans, we'd be happy, but we don't assume that the cancer is actually gone in that case. We just say it's too small to see. So really, we're just trying to make sure it doesn't get worse. And around 5 months, our surgical team would do a diagnostic laparoscopy, which is just a quick look to see if there's how much cancer there is, what are the locations, to do that PCI score and have some sense of what is our starting point, so that, you know, Dr. Mogal or whoever the surgeon would be would have an idea of what he's getting himself into when he actually goes through the surgery. And really a key point of this, just as he reiterated, is we need frequent multidisciplinary review, meaning that we need to be constantly discussing as a group to make sure that we are in the right place medically, physically, mentally to do the surgery if that's the route we're going to go. So we have very limited data for how we guide chemotherapy. A lot of it is based on retrospective series where they look back at patients that have been previously treated. But we have one study that really looked at the use of chemotherapy before and after surgery for patients with colorectal cancer that was metastatic to the peritoneum. So the problem with this study is it wasn't really consistent. It wasn't one way of treating things. They allowed different patients chemotherapy regimens, and it was often up to the patient and the physician to decide together what was the best chemotherapy regimen. So in this case, we had 37 patients that got chemotherapy, and they got a variety of different chemotherapy regimens. You'll see that most of them got 2 chemotherapy drugs, and some of them also got bevacizumab. But none of them got our triplet chemotherapy FOLFOXIRI because this time predated when that was really done. 89% of them were able to have complete cytoreductive surgery and Hypex, and then they were recommended to get chemotherapy after. Now, just as Dr. Mogal said, recovery is not always as fast as we would like. There could be complications. Some patients are just slow to get back on their feet. And so it would be harmful to start chemotherapy if someone is not healed up well enough to be able to tolerate it. So unfortunately, in this trial, only 32% of patients actually got all planned chemotherapy. Now, on the other hand, 42 patients were supposed to go with upfront surgery. But you'll note that not all of them were able to have complete cytoreductive surgery and Hypex, only 86%, meaning that the surgeon might have gone in there, opened them up, and realized that the burden of disease was too high to be able to operate on. So what we can take away from this study is that giving chemotherapy beforehand did not seem to prevent someone from going to surgery, because actually a few more percent of patients did get to have surgery, and that it was difficult to get chemotherapy afterwards. And I should also mention that the perioperative complications were similar, so recovery was similar for the 2 groups. So based on this, even though it didn't directly tell us to do all chemotherapy first, we go in with that mindset that we want to maximize the amount of chemotherapy someone receives before surgery, because we really don't know if someone is going to be able to do chemo afterwards or not. Now, it's never as simple as just one plan for all patients. We know that there's a lot of rare mutations that we need to test for because we have targeted therapies for certain ones. Now, these are rare. Less than 5% of metastatic colorectal cancer will have each one. So we look for genes BRAF, HER2, microsatellite instability, NTRK. These are all ones that help us opt in or add a potential drug. There's other ones I didn't mention, KRAS, NRAS, which tell us not to give certain drugs. So we use these different drug mutations to help us find out if a particular patient has additional treatment options that not everyone might have. I want to especially highlight dostarlimab because it's got a lot of press lately. This was a PD-1 inhibitor or an immunotherapy drug given for localized rectal cancer, so completely different patient population that we're talking now. But it had a lot of press because it had a 100% complete response rate when given instead of surgery. This is very interesting, but I do want you all to rest assured that we know to test for microsatellite instability. This is already approved for metastatic cancer. So for anyone who has peritoneal disease, this information, while very exciting with the new trial, is kind of old news for patients with metastatic disease, and we know to be testing for this marker. What do we do after surgery? So we're going to be seeing you in surveillance for at least 5 years. Dr. Mogal talked about the initial post-operative period, but then usually your medical oncologist is following you, asking about symptoms, especially ones that might relate to active disease in the abdomen, blood tests, including tumor markers. scopes like endoscopy or colonoscopy, and scans, typically CT scans, but sometimes we'll use a PET scan or MRI if we have indeterminate findings. But even with all of these different tests, we know that recurrences can still be hard to detect. So bringing everyone back to high school biology, we have different ways of trying to track cancer. So we have DNA, which turns to RNA, and from there you can translate to proteins. You can have a single cell that is involved with cancer, and when it replicates, it makes a blob of cancer that we call a tumor. So to actually test a cancer, we typically talk about a tissue biopsy, where they go in with a needle, where the surgeon will, and take a piece of the tissue, which is a whole chunk of tumor cells that we can then look at and try to get some information about how the cancer grows. But we also have blood-based markers. And so classically, that's been things like CEA, which is a protein made by the cancer that some make and some don't. But now we have these newer so-called liquid biopsies where you're looking for circulating tumor DNA. So you're actually looking for a different byproduct of the cancer. So what is this? All of our bodies have DNA floating around in the bloodstream. So when cells break apart, which is part of the normal cell turnover process, they release DNA into the bloodstream. And so we call that cell-free DNA. It only lasts for a couple of hours, and then the body kind of takes rid of the cellular garbage and reuses what it needs. But some of these markers could actually give us some information. So as a screening tool, this first applied to pregnant women. So they called it prenatal aneuploidy screening. And basically they were using it to look for birth defects like trisomy 21 or Down syndrome to help inform a mother if she was likely to have a baby that had a birth defect. But we can also look for different DNA mutations, and we call that circulating tumor DNA when we're looking for mutations that are likely specific for the cancer. Again, this is a real-time measurement. It only lasts for a couple of hours, and it's easiest to detect the more cancer you have in the body. So we can use it in a couple of different fashions. The main reason that I use it in my practice and that I'm doing in my research is to look at this concept of what they call MRD, which either could stand for molecular residual disease or minimal residual disease, but it's effectively the concept of looking for small volume disease that can't be seen on scans or any other clinical measure. And so we think that ctDNA could be a useful biomarker to evaluate this, meaning could ctDNA pick up recurrences faster than how we do regular scans or blood tests? But the problem is that most of our analyses have been looking back, meaning retrospective, and observational, meaning that the blood tests were taken along the way, but they weren't actually really guiding clinical practice. So that has a lot of bias in it. So we are not quite sure what to do with that information. So how does this matter? So let's say we have all patients in this middle line, the black line. And so again, we said 100% of them are alive, and in this case, recurrence-free. So nobody has cancer at the start. And then we're following patients, and we know that some patients' cancer will recur. The idea here is if that person does not have detectable ctDNA, or they're ctDNA negative, we've noticed that they do much better. And so then you see the blue line at the top. So maybe those patients who are ctDNA negative don't need as aggressive a therapy. On the other hand, patients who have detectable ctDNA have a near 100% chance of recurrence. And so we see higher likelihood of recurrence. That's the ctDNA positive arm in the red. And so maybe those patients should have more aggressive therapy than standard. So what we're hoping to do here is better risk stratify patients to understand who needs toxic chemotherapy, radiation, whatever, and who does not. So there's lots of studies to share, but I'm just going to show a limited amount. So this was one done from Australia in stage 3 colon cancer patients. They all had surgery followed by chemotherapy, and along the way, they collected blood samples to detect ctDNA. They noticed that 21% were positive after surgery, and then after chemotherapy, that went down to 17%. In this study, 25% had a recurrence, and the majority of those were patients who were ctDNA positive. So that was very interesting. But I think it's even more interesting when you look not just at one time point, but actually look at subsequent time points. So after surgery, looking at, RFS is recurrence-free survival, or the likelihood that they're alive and cancer-free at 3 years. So in patients right after surgery, if you're ctDNA positive, you had a lower likelihood of being alive and recurrence-free than if you were negative. And when we looked after chemotherapy, the numbers even went more polar opposites. So really, it seems that following patients over time is helpful. Putting this another way, on the left graph, you have patients who are positive right after surgery. If they turned negative, presumably because of their chemotherapy, then they did better than the patients who stayed positive. It didn't mean that you never had a recurrence in the negative patients, but that overall that patient group did better. On the other hand, on the right, you have the patients who were negative after surgery. If they stayed negative, they did the best overall. But patients who were negative and later did turn positive, basically all recurred. So one time point is helpful, but following this as a blood-based marker can be very helpful. We do have data in stage 4 as well. So again, this is more observational data, but in this particular study, this was looking before surgery, all patients had detectable ctDNA. When they looked right after surgery, about half of them had a positive MRD time point, meaning they had detectable ctDNA. It got suppressed during chemotherapy to 33%, so some of them went negative briefly. But then in the surveillance time period after chemotherapy was all done, still about half of them stayed ctDNA positive. And this is sort of what we expect, which is in patients with stage 4 cancer who are treated with surgery, even when we think we got it all, even when patients have the best risk disease, there's still about a 50-50 recurrence risk. And so this is mimicking that here. This has been shown again with other studies. This is another stage 4 study. And here again, about half of patients were positive after surgery. And I just want to highlight the differences that you want the curves to be as separate as possible, because the best biomarker would be something that would tell you absolutely what's going to happen. So with one time point, you see some separation of the curves, but with 2 time points, you see even better separation. And again, maintaining being ctDNA negative seems to be the best prognosis. So what do we actually do in clinic? So we're going to take all this information that we know and apply it to a specific patient, thinking about what is the goal of our therapy? Are we planning surgery? Are we not planning surgery? How aggressive can that regimen need to be? What types of therapy has the person already had? Because I'm going to look back and think, did they have chemotherapy after surgery in the past? Are they on chemotherapy now? What can we do to modify this? What other medical issues does that person have? Some people have another issue that would prevent them from getting a certain chemotherapy drug. Has that tumor molecular testing been done? Does this person have a unique treatment option that we could do? Maybe they have a BRAF mutation. Maybe they can have immunotherapy. So we want to expose them to all drugs possible. And should we basically add or remove drugs to try and better prepare the person for surgery? But finally, the overarching question is, does an attempt at surgery make sense? Because that is going to completely dictate how we guide therapy and how we talk to a particular patient. So all of these questions go into the counseling that we will do, both as we discuss in our tumor board and throughout our different patient interactions. And that's all I had to share with you today. So I know that was kind of a quick overview, but it is now my pleasure to introduce Dr. Goff, who's my esteemed colleague. She is a physician at Seattle Cancer Care Alliance. She is a professor of the Division of Gynecologic Oncology at the University of Washington, chairing the OBGYN department, and a surgeon-in-chief for the UW Medical Center, as well as an investigator at the Fred Hutch. And so with this, I'd like to turn it over, and I'll be looking to the chat for any questions. Thank you.
Great, thank you very much. So let me just get this back. Okay, so I'm going to talk very quickly about HIPEC in ovarian cancer. And this is a therapeutic modality that has recently started to emerge as something that we're doing more frequently, but for very narrow indications. So as we think about ovarian cancer, I know most of the people on the line are probably people interested in GI and appendiceal cancers, but ovarian cancer is actually the second most common gynecologic cancer in the US. but it's the most deadly. The overall survival, even when you take stage 1 through 4 altogether, is still less than 50%. And the vast majority of people actually present with advanced stage disease where the cancer has spread throughout the abdominal cavity and typically tends to be very peritoneal based, which is why ovarian cancer really needs to be included in these peritoneal cavities. So basically with ovarian cancer, it starts in the ovaries, it can spread to the regional lymph nodes, but very quickly the cancer sort of breaks off and then it'll start implanting in the omentum and you'll get nodules in the omentum. Sometimes you can get very large masses in the omentum, and we call these omental cakes because it's just a big cake of tumor. But you can see here, it's not uncommon to see these tumor nodules implanting on the omentum, on the peritoneal surface. Here you can see them on the intestine, sort of where the blood vessels of the near the intestine are. This is the small bowel here, and you can see these implants just going on the mesentery. And so this is very common for ovarian cancer to spread this way. And it tends, for the most part, to stay in the abdominal cavity. Things like liver metastasis, lung metastasis are actually pretty unusual for ovarian cancer. And so intraperitoneal treatments for ovarian cancer have actually been around for a long time. So actually, way back in 2006, the National Cancer Institute issued a clinical alert for ovarian cancer, and NCI doesn't issue clinical alerts very often. Prior to this, the last one had been in 1998, actually for cervical cancer. So this is very unusual that the NCI would do this, but they issue alerts when they feel that there is a major advantage to a therapy and that everyone should know about it pretty quickly. So in 2006, there had been a trial that was published that compared standard intravenous chemotherapy, 6 treatments, versus intraperitoneal and IV chemotherapy after surgery in people with stage 3 disease. And what they found was that for ovarian cancer, that survival was extended by over a year by using the intraperitoneal chemotherapy with IV as compared to the IV alone. And so the patients had to have stage 3 disease. The surgery had to be successful in removing almost all the cancer. In this case, patients were allowed to have up to 1 centimeter of disease left behind. And survival, as I said, was much better with 6 treatments compared to just the 6 treatments of IV. And for those patients who were optimally cytoreduced to no gross residual disease, what we would call R0, those patients had an even better 5-year survival, and it was over 50%, which was very significant. So for at least a decade, intraperitoneal chemotherapy for ovarian cancer was really considered the standard of care. In fact, it was considered a quality metric for NCCN cancer centers. And so we were judged by what percentage of our patients actually received intraperitoneal chemotherapy. Now, with the intraperitoneal chemotherapy, we did see higher toxicity rates. There was more abdominal pain, there was more nausea, there was more neuropathy, which is numbness in the hands and feet. We had lower blood counts, and so people were more likely to need blood transfusions or need medications like Neupogen or Neulasta to keep their white blood cell counts high enough to continue to receive chemotherapy. And we did see catheter complications. Catheters would fail. Sometimes people would get bowel blockages because the bowel would wrap around the catheter, and so there were higher complication rates. Interestingly, though, now with new drug combinations, and particularly with our ability to give maintenance chemotherapy or maintenance targeted drugs to almost all patients with ovarian cancer, the survival advantage with IP chemotherapy disappeared. And so it's sort of fallen out of favor. There are now very few indications that we use intraperitoneal chemotherapy for, but there's a long tradition and a long history of IP chemotherapy in the treatment of ovarian cancer because it is a peritoneal-based tumor that tends to stay in the abdomen. So recently, people have been looking at HIPEC in ovarian cancer, and again, seeing some of the successes that we see with pseudomyxoma peritonei, appendiceal cancer, colorectal cancer. There have been a number of trials that have looked at using this HIPEC modality in women with ovarian cancer. And so people have looked at HIPEC after surgery at the initial diagnosis when patients are, they're diagnosed, they're taken to surgery. And then at the time of surgery, we flip a coin and the patient will get HIPEC, or they'll be closed and then they'll just get regular standard intravenous chemotherapy. We've also looked at it where patients get neoadjuvant chemotherapy, which means chemotherapy before surgery to try to shrink the cancer down to make the surgery more successful. And again, at the time of surgery, a coin is flipped and people are randomized either to the heated intraperitoneal chemotherapy or they're closed and they receive just standard chemotherapy, which in ovarian cancer would be a combination of a drug called Taxol and another drug called carboplatin. And then it's also been evaluated in recurrent ovarian cancer. And this is when people have a more prolonged period of time between completion of initial chemotherapy and when the recurrence happens. It has to be at least 6 months. And then again, those patients are taken to surgery. They're randomized at surgery to either the intraperitoneal chemotherapy or they're just closed and receive regular chemotherapy. And in ovarian cancer, all patients after HIPEC should receive additional chemotherapy. Let's see. So with HIPEC and ovarian cancer, we only use cisplatin or carboplatin. Those are the only two medications that have been used. Cisplatin is definitely a little bit more toxic than the carboplatin, but in the studies that have been successful, it's been cisplatin that has been used and not the carboplatin. And so I think there is concern about using carboplatin in HIPEC, but with cisplatin, we have issues with kidney toxicity, more neuropathy, but these can be mitigated with some pre-treatment and again, aggressive hydration of patients prior to receiving these medications. Like in colorectal cancer, the chemotherapy is heated to 40 to 43 degrees Celsius. We typically will use this for 90 minutes in the abdominal cavity. And it's important to say that this can only be done if when you do the surgery is successful, so that you are getting either absolutely everything or down to very, very small volume disease. And again, the goal should always be to have no gross residual disease, because that, just like colorectal cancer, GI cancers, this is where we see the biggest benefit and where we see the risk-benefit ratio really start to turn in ovarian cancer. So this is from a recent study that was published. This is actually out of Korea. It was just published a couple months ago. And this was a study looking at upfront surgery. So patients were high likelihood of having ovarian cancer based upon their CAT scan and their tumor markers. In ovarian cancer, CA125 is the tumor marker that we use to follow ovarian cancer. And so these women, again, taken to surgery. Once the surgery has been deemed successful, that's when they flip a coin and they either get the HIPEC, which would be the cisplatin in this case, for 90 minutes, or they're closed and they get standard chemotherapy, which would be 6 treatments of carboplatin and paclitaxel in the postoperative period. And that lasts for about 6 months after the surgery. And you can see in this situation that the patients who were closed and who did not get HIPEC surgery actually had a better outcome. So this is probably not a group of patients that you would want to offer the HIPEC to, because we're not seeing a survival advantage. And again, you can see out here the control group at 10 years, having about a 60% chance of survival, compared with the HIPEC out here, which was 40%. So if you're a patient, you definitely want to be on this curve here. Now, what's interesting is that we now have 2 studies after neoadjuvant chemotherapy, which tell a different story. So again, we're looking at the survival curves, and in this case, patients received 3 treatments of carboplatin and paclitaxel. They were then taken to surgery, and if the surgery was successful, a coin was flipped, and they either received the HIPEC or they were closed and went on to receive 3 additional cycles of carboplatin and paclitaxel. And in this study, you can see that the patients with surgery plus HIPEC had a significant survival advantage. So again, at 5 years here, we're seeing, survival rates of a little bit under 50%, and with surgery alone, under 30%. And so again, very significant survival advantage here. Another study, again, same thing. We're seeing that with the neoadjuvant chemotherapy, the HIPEC group having a much better survival than the control group. So again, these are 2 studies. We don't have a ton of studies, but definitely suggesting that this is sort of the narrow indication where we should really be strongly considering HIPEC in this group of patients. Now, it's also been looked at the time of recurrent ovarian cancer, and these would be in patients with favorable recurrence, meaning that they recurred more than 6 months from completing their chemotherapy. And in fact, most of these people, it had been more like a year before that they had gone before having a recurrence. And in this study, what they did is they took these patients to surgery. Again, they were randomized. A coin was tossed in the operating room if the operation had been successful. And in this case, they used HIPEC with carboplatin rather than cisplatin. And they saw that there was no survival advantage between the 2 groups. So we don't know if it was that HIPEC wasn't effective, or was it that carboplatin wasn't effective? And so this is a group I think we still need to go on and study additionally using the cisplatin. And there are studies that are ongoing that are looking at this, very important group of patients. In patients who have a recurrence within 6 months of completing therapy, I think Dr. Mogal talked about this, the prognosis isn't very good. And so for these patients, the risk and the morbidity of proceeding with HIPEC, or if you've had multiple recurrences, there seems to be no survival advantage in using HIPEC in these patients. So side effects, really very similar to what Dr. Mogal has already described. We don't see things that are different with ovarian cancer than we do with other cancers, except for when we use these very high doses of cisplatin, we have to be very concerned about kidney damage. And again, important to have a multidisciplinary team who understands using these high-risk drugs in high doses and understand how do we prevent complications from happening. And so again, very important to be in a HIPEC center if you're undergoing this treatment. In the studies that I showed you, the most recent studies, mortality does not appear to be increased with the use of HIPEC. So in all of those studies, they didn't see that the complication rate or the mortality rate was really that much higher with HIPEC than it was just with very, very aggressive surgery followed by chemotherapy afterwards. There is a pretty high complication rate, 25 to 30% serious complications, but is again, not significantly higher than surgery without HIPEC, which again, I think is very reassuring for those of us who are offering this to our patients. Average hospital stay in these studies was 8 to 10 days. So again, very similar to the data that Dr. Mogal presented. And in these studies, they actually looked at long-term quality of life to see, did it decline compared to people who did not get HIPEC? And again, reassuring, I think, to see that long-term quality of life was actually not worse in the patients who got HIPEC. So again, I think reassuring for me as a provider who's offering this to my patients. And I think we're going to take a break, right? And then we can save questions for the panel. And I've put our clinic number. So if any of you are interested in HIPEC for ovarian cancer, this is the GYN oncology clinic number, and we're happy to set up a consultation. And usually we do these joint consultations with Dr. Mogal and one of the GYN oncologists, so that again, it's a multidisciplinary team. And so even though you have a GYN tumor, we have full access to everything that Dr. Mogal and the HIPEC team is doing, and we work very closely together. So thanks.
Thank you so much, Dr. Goff. Yes, at this time, we are going to take a break. I'm going to, excuse me, we are going to take a break. We are going to resume at 10:15. So we're going to shorten our break by about 5 minutes. We'd like to see everybody back here at 10:15. Thanks so much.
Okay. I just thought it would be beneficial for folks to hear about the program at SCCA and UW. As Dr. Goff already mentioned, we have a fairly involved multidisciplinary team that comes together from different aspects of the institution to help take care of these patients. Many of you have already been through multiple treatments, have been to multiple other institutions, and you know the importance of a good team that takes care of you throughout your cancer journey, whether it's from the time you enter our doors to seek consultation, to your planning of your chemotherapy, your surgery, and then your long-term follow-up. So at UW, we truly believe in a patient-centered model. So everything that we do in the HIPEC program and how we have structured this program is all kind of centered around what our patients need. You know, when we started this program back in the fall of 2020, we wanted to make sure that the patients were put first. So as far as our clinical care was concerned, we wanted to make it easily accessible so that providers as well as patients alike can reach out to us and come see us in the office. We instituted obviously a multidisciplinary HIPEC team, and you are seeing some of us today, including Dr. Goff, Dr. Cohen, myself, and then a bunch of other members of this team that you will have a chance to hear from later in this webinar. We believe in integrating supportive care services, so patients who are believers in some of these other integrative services, we always recommend that they continue treatments, not outside of standard of care treatments, but with standard of care treatments. We have standardized our pathways in terms of how we provide patients care. We aim to become a regional and a national leader, and you will see some of our numbers later on that sort of bear this out. And then we want to stick to national benchmarks, which are not necessarily well established, but which are somewhat developed based on consensus. Education is a huge part of this process, and that's why we have one of these events today. We will hopefully have provider-related events starting in the coming year. As far as our research platform is concerned, Dr. Cohen already took you through some of the research that she has been very heavily involved in with respect to ctDNA. We are in the process of instituting our own data bank, and hopefully this will be linked with tissue so that we can study the patient's diseases and answer questions that really need answers. We participate in multi-institutional cooperatives, including national cooperatives through the SWOG, as well as the ECOG regarding trials that are being contemplated for patients undergoing CRS HIPEC. And lastly, we truly believe in community engagement for all of our patients. So while many of our patients are internal referrals, a vast proportion of them are external. And we want to make sure that your care is delivered best where you feel most comfortable. So when it comes to having your consultations with us and us having directing your care, we want to make sure that you can still receive that care in the community. And a lot of this coordination is done by some of our outstanding team members, some of whom you'll meet today. So when we started this program, we not only built the team, we established the multidisciplinary tumor board so that we centralize care for all HIPEC patients. Our goal was to ramp up clinical volume, which we have done, standardize many of these algorithms, including care maps, which many of you get at the time of your preoperative consultations, our chemo preparation and delivery protocols, how we standardize our operative reports so they can be universally read by patients as well as providers alike. And then how we manage our patients post-operatively using specific protocols called ERAS protocols, or Enhanced Recovery After Surgery Pathways. We've also standardized how we report pathology. As a lot of you know, pathology is paramount in terms of us providing you the right kind of treatment plan. During our HIPEC multi-clinic meetings, we aim to select patients for surgery based on the available information. All of our patients have their pathology and radiology reviewed prior to their clinic appointment. And this is very essential because, for example, in patients with appendix cancer, one, because it's so rare, and two, because there are so many different types of appendix cancer, oftentimes we notice that even though patients have been rendered a diagnosis at an institution where they don't see appendix cancer very often, when we review their path, many times there are additional aspects that come to light that may warrant a change in treatment strategy. We do multi-D consultations with various members of the surgical team, the medical oncology team, and in case of ovarian cancer, always the GYN oncology team, that's the point of contact. And GYN oncology is also very heavily involved in our patient, specifically in our female patients who have to have extensive pelvic surgery, or when it comes to questions about fertility preservation, or long-term follow-up when they've had their uterus and tubes, etc., removed. Preparation for surgery is extremely essential. Most patients will meet with our nurse within the clinic for an extensive amount of surgical education. Our prehab team that also does rehab at least screens and many times does in-person evaluation on patients, especially those who are concerned about their physical performance. And then nutrition is a huge part of preoperative as well as postoperative management. And we'll hear a little bit more about that from our panel today. Coordinating care in the perioperative period is complex because these are big operations that last 10, 12, 14 hours. So our anesthesia colleagues are very involved. They were involved in developing some of these pathways to help with postoperative pain, etc. In the OR, there's a whole other team that's basically, again, dedicated to taking care of HIPEC patients, including perfusionists who are assigned to the operation every time we have to do one. And then postoperative follow-up is really intense, usually every week for the first several weeks until we make sure patients are through the acute hump. And then long-term surveillance in our clinic, either directly with our clinic or sometimes in concert with our community partners, for example, medical oncologists in the community. As many of you have already noticed, our clinics are fairly busy already. We started the multi-D HIPEC clinic itself in April, and since then our clinic utilization has been significantly high. Most of our referrals, like we talked about earlier, are external referrals, and many of them are internal, but a lot of them are external and other referrals. We've done several operations of this kind. This graph basically demonstrates all types of surgeries we do on patients with peritoneal cancer or appendix cancer with peritoneal disease. And not all of these are HIPEC because sometimes there are unique situations in which HIPEC is not necessarily warranted, or we do laparoscopies for staging, or we do complex appendix cancers that have not disseminated into the peritoneum. But we've done close to 50 of these since November of 2020. And we're very proud of the team that has been able to achieve this in a short period of time and gain the kind of experience we need to give patients excellent outcomes. We have care maps that we've developed for CRS HIPEC patients that we give patients at the time of their preoperative counseling so that they know exactly what to expect in the days leading up to and even after surgery. We have standardized pathways like we talked about, especially the ERAS pathways, that's standardized care for all of our patients. We know this from large-scale studies in different other disease sites that standardizing postoperative care in terms of a pathway enhances the patient's ability to move through their postoperative period and discharge from the hospital, which are important. We've developed several educational materials that are available either at the time of your appointment or on our websites. We have a multi-D tumor board, which we started in January of this year with the participation of pathology. We review patients' scans, their pathologies reviewed. We have a comprehensive discussion about what to do in terms of a plan. And this is not only for new patients that are coming into our clinic, but also patients who are returning, say, for example, with recurrent tumors or with surveillance scans to make sure that there's nothing that we're missing. Extensive collaboration with our GYN oncology colleagues under leadership of Dr. Goff. We have now been able to start offering HIPEC for ovarian cancer patients. We did our very first case in March. And we only will continue to expand this aspect of our program. We've been able to institute our patient education event, which the first one of which is today. This was kind of an important aspect of our multi-pronged approach towards treating patients, because I know the information that's out there is lacking in general, and oftentimes patients don't know where to sort of come to for comprehensive information. So we aim to have this event every year, and hopefully next year onwards in person. We have a dedicated website that can give you a lot of information, not only about HIPEC, but also about the people and the personnel involved in the program. Our program has grown substantially in the last year and a half, and we have already recruited a few faculty to help out with our efforts to manage patients as best, in the best possible manner. And so Natalie Williams, who joined us last year in December, is one of our inpatient nurse practitioners who, for large part, helps manage our postoperative patients at UW that undergo CRS HIPEC. Lara Worley is our new faculty member that will be joining us, and she will largely be helping coordinate care and take care of patients and see them in the HIPEC clinic, especially some of our postoperative visits or coordinating care for patients that are having issues after surgery, etc. We also recruited another surgeon to help out with CRS HIPEC procedures, as well as sarcoma procedures later this year. His name is Dr. Sherib. Comes highly recommended, and we're very excited for him to join us as part of our team. And I'm sure with all of these efforts, we will be able to streamline care for our patients even more and ensure that patients that need to get into the door and be managed are managed in a timely fashion. And last but not least, my only regret with this slide is that I couldn't put more people on it, because there are tremendously way more number of people that that are involved in this program that make it successful and bring people together. But this is sort of a general idea of what it takes to put a program like this together and to make sure that patients get the best possible outcome. I can tell you with conviction that every one of these folks that you're seeing on this slide is very vested in taking care of our complex CRS HIPEC patients. And with that, I will stop. And we can.
Oh, sorry. I was just saying, next we're having our panel discussion. And I do have a very simple slide that says panel discussion, but I'm guessing people would rather see all the faces of folks rather than my slide that says panel discussion. So I will leave that down.
Okay, great. Thank you so much. So we have a few of our members here that we're excited to welcome. I'm just going to go in order of how I see them. Dr. Goff, you have already had an introduction to her. She leads, she's the chair of GYN at UW and an instrumental component of our UW and FHCC HIPEC program. Stacey Cohen is our a medical oncologist who is co-lead of the HIPEC multi-D clinic at SCCA. Tal Ozery is our dietitian who works very, very closely with our HIPEC patients. Many of you have already had multiple interactions with her. Jenica Holt is from our Department of Physical Medicine and Rehabilitation. She does physical therapy and is an lymphedema certified physical therapist also. helps evaluate our patients pre-op and also manage a lot of their deconditioning issues post-op. Natalie Williams, as you just saw, is one of the newer members of our team who helps manage our patients in the hospital. Allyssa Dwyer is our surgical nurse coordinator, who does a lot of our perioperative coordination as well as a lot of our patient navigation. Natasha Hayder is our OR PCC who helps coordinate a lot of our operations in the operating room so that things run smoothly. So with that, I can possibly start with Tal. Tal, can you speak to the importance of nutrition both before and after treating patients with CRS HIPEC?
Absolutely. So I'm Tal. I'm the dietitian that's here on Dr. Mogal's team. Just to give you kind of a general overview of the process. So I generally will meet with patients pre-surgery, and this gives me an opportunity to get an idea of your diet, your current kind of nutritional status, have you lost weight previously? And this really helps us to optimize your nutrition before surgery, which is so important that you are in that nourished state so you're able to recover quickly from surgery and allow your wounds to heal quicker. And so we optimize nutrition pre-surgery. And then after surgery, typically some of the challenges that I see, I would say the most common are feeling full very quickly and just the general lack of interest in food. So I generally meet with patients quite frequently, maybe once or twice a week, to help troubleshoot some of these issues, assess your diet to maximize calories, and we can get really creative with that. Let's see, some of the other side effects that I see are a little bit less common, so like diarrhea, constipation, and nausea. And there's a lot that you can do with food to help mitigate some of those side effects. So it can be really helpful just to talk things through with me, and I can assess your diet. And the importance of nutrition really is to help you maintain your weight and specifically maintain that muscle mass that makes you feel more resilient. And I'm sure Jenica will speak more to that. So, yeah.
Great, thank you, Tal. Allyssa, next I'd like to turn it over to you and I'd like to ask, how do you describe sort of the nurse, clinical nurse coordinator role for our patients, and specifically at SCCA, how do you help kind of coordinate all of the different aspects of care for patients, especially ones that are might have a local medical oncologist but are getting surgery at the University of Washington?
Yeah, so when you're initially kind of referred over to Dr. Mogal or the HIPEC team, we kind of help to make sure that we've got all of your images, all your labs, all the information that the physicians need to make an informed treatment plan. And then at that point, once you're seen in clinic, I'll get to meet you in person, and I'm kind of your main resource and like go-to person. So as you can see, there's a lot of people involved in the team, but it's nice to just have one person to go to, and I can kind of be your middleman and make sure that if you're struggling with nutrition, I get you over to Tal, or if you're struggling with kind of recovery and being active afterwards, we can get you over to Jenica. Just making sure that you have all of the resources and support that any patient would need. That includes things like transportation and kind of logistical, like where you're going to stay if you need to, if you live kind of further out and need to stay in Seattle post-operatively for those weekly visits afterwards. Just any kind of logistical or clinical needs, I'm kind of your go-to person.
Great. Jenica, so, a lot of our patients that we select for CRS HIPEC tend to be relatively overall quite in relatively decent shape. But we almost always routinely have them evaluated by our physical therapists. Can you speak to the role of why is it important for us to kind of look at that routinely in patients, and what happens to patients after surgery, and what can we do before surgery to kind of optimize their condition so that their recovery is much more smoother?
Yeah, very similar to Tal, we're seeing most patients pre and post-op. And the pre-op assessment is really just to make sure patients are as functionally mobile and fit and prepared pre-surgery. A lot of times they're already coming in very mobile, but part of my job is to also educate on the role of physical therapy at the different stages. So pre-op, you're seeing me, and then in the hospital, hospital, you should be seeing physical therapy as well, working on recovery right after Hypex surgery. And then post-operatively, if I get the chance to see you after, it's making recommendations and coming up with sort of a treatment plan on how to get you back to your goals and activities of daily living. A lot of times working on strengthening or managing fatigue or other side effects that come after Hypex surgery. I think another part of my role is also to find providers within the community that maybe patients can connect with. And oftentimes I'll give my information and also try to connect with physical therapists closer to home so that we're all on the same page about goals for recovery after surgery.
Thank you. And what are the common things you recommend patients in their day-to-day activities, for example, pre and post-op, that they can do within, say, the confines of their home, et cetera, to kind of optimize their physical functioning?
Yeah, I think the main things that we'll hit on is cardiovascular exercise and then also general strengthening. If they're not already doing that, we're recommending that pre-operatively you're on some sort of walking program or cardiovascular program just to make sure we're maximizing cardiovascular function. And then also focusing on some sort of strengthening, and that's where a consult can help sort of fill in the gaps for patients to give them specific exercises. But we're also recommending that post-operatively, they're also working on walking a few days after surgery if they're cleared by their medical team to do so and it's safe to do so, to make sure we're kind of gradually getting them back to exercise and rebuilding that strength that may be lost after hospitalization.
Great. Dr. Goff, sometimes we have patients, unfortunately, who are diagnosed with peritoneal malignancy, say at the time of a C-section or an unrelated GYN procedure. Oftentimes, these patients are younger and in their reproductive years. What is the feasibility of, say, for example, fertility preservation in younger patients who desire to preserve fertility, especially knowing that, say, for example, in appendix cancers, the ovaries are sort of a high affinity site for patients to develop disease. Do we have any teams here at UW that can help with making some of those decisions for patients?
Yeah, absolutely. We have a whole reproductive and endocrinology and infertility division. Their clinic is located on the UW campus on the Roosevelt site, and it's called University Reproductive Care. And for patients who have cancer, they actually consider this an emergency. And so they will do emergency consultations, meaning that you'll be seen within a couple of days. To discuss sort of what are the options, look to see, what sort of funding there might be through Livestrong or other organizations. And then they work very quickly to try to get the ovaries stimulated before we start chemotherapy or before we do radical surgery so that we can preserve eggs or potentially embryos. But now the success rate of IVF with frozen eggs is as good as it is with frozen embryos. And so getting the eggs can sometimes be a faster and quicker thing to do, but usually they can get eggs harvested within a couple of weeks so that there's very little delay of chemotherapy. And in very, very young people, like at Children's, we also have a program where we harvest part of the ovary. So in kids with leukemia who really have to have chemotherapy like within a couple of days, we have the ability to shave off some of the ovarian cortex and freeze it and save it. And then you can re-implant it after that. So we have a number of different things that we can do. And of course, for men, it's a lot easier for them to bank sperm. And we have a great sperm banking program as well too. So there are a lot of opportunities for people who are young who want to consider fertility preservation.
Great, thank you so much for providing our patients that resource. Another question that frequently comes up, Dr. Goff, especially for patients who are, again, younger, who we abruptly move into menopause because we do a hysterectomy and bilateral, ovarian removal, is what can they do in terms of strategies to minimize symptoms? When should they be starting some of their hormone replacement, and is it even safe to do that?
Yeah, Dr. Mogal, that's a really good question, because to some extent it depends on the histology of the tumor and whether it expresses estrogen receptors or progesterone receptors. For most GI tumors, there's really not going to be a contraindication to starting hormonal therapy. The one thing we have to be careful of is in the immediate post-operative period with these large operations that we do, that there is an increased risk of blood clots, particularly, in the legs and in the pelvis. And so sometimes estrogen can be associated with a hypercoagulable state. So we have to just be very careful in using relatively low doses, at least at the time of right around the time of surgery, until people get through their highest risk of blood clots. But then typically we can go up with standard doses of hormone replacement.
Great. Natalie, having been in this program for several months now and having taken care of patients on the floor, what unique issues have you noticed with these patients, especially in terms of their immediate post-operative recovery that, we see our role helping with?
I have the distinct pleasure of working with patients in the inpatient side and providing care and managing and coordinating care with multidisciplinary teams, including nutrition, physical therapy, social work, coordinating case managers. So on that end of it, it's like primarily assessing and optimizing recovery, making sure that patients are up and out of bed, their pain is well controlled. I see there's complex pain management needs that are necessary, complex nutritional needs, making sure that coordinating with nutrition, making sure that we're coordinating with pharmacy on any education that is needed for medications. And then also on the coordination of discharge planning, so that we are setting them up with their primary care provider or for surveillance studies to follow up with the outpatient team and making sure that they are well set for follow-up visits and that. So.
Great. And Allyssa, so some of our patients obviously are not local and they live somewhat far away. What is our strategy for helping some of these patients at least navigate their first few weeks after surgery? What kind of resources are we able to provide them, at the SCCA and UW to help with that?
Yeah, so the SCCA has a lot of resources available. There is a couple different lodging options for patients that offer lodging at much more affordable rates than if you were to try to find a hotel, for instance, in Seattle. So it makes it a little bit more accessible for patients to be able to stay. And they have, kind of kitchen accommodations that you don't have to be trying to eat out every meal, especially initially after surgery when your diet is a little bit kind of limited anyway. So there's lots of resources, and I stay in communication with local medical oncologists to make sure that the plan is kind of as seamless as possible. The HIPEC multi-D team here at SCCA is, of course, very specialized, and so local medical oncologists might not know what the full plan is. So I feel like keeping communication open between those teams is important. But initially, after post-op, that kind of 4-week period when people are coming in weekly, usually we try to arrange for a stay in Seattle so that if anything were to come up emergently, you'd be able to see that multi-D team.
Great. And also another reminder to a lot of our patients who may not necessarily live in the area, one of the boons of this pandemic, which obviously a lot of us have had to sort of struggle through, is that we now have access to telehealth at a much larger scale than we had before. And so some of our providers are licensed outside of the state, and all of us are definitely licensed within the state. So sometimes we can do consultations via telehealth or even do postoperative checks if it doesn't require patients to physically be in the clinic via telehealth. And that's been a really great resource for us to use, especially when it comes to patients, wanting to go home sooner and recover sooner in the comfort of their home rather than staying in the local area. So that's another thing that, at least at SCCA, we strive to provide. So something to keep in mind.
I'd like to ask a question. This is, I guess, to Allyssa, to Tal, to Jenica. A lot of patients will ask, when do we get back to normal life? So what do you tend to tell patients? Because, the recovery process, there's the acute recovery process that Natalie is so involved with. Then there's that immediate time when you're getting on your weekly clinic visits. When can they kind of be normal again?
I'll start. So for nutrition, I think there is the kind of like what Stacey, Dr. Cohen was just referring to, the acute recovery period afterwards. I would say, anywhere from 4 to 6 weeks, your appetite is severely impacted by this lack of interest of food, feeling full frequently. At that point, there's a kind of gradual process returning back to normal. Appetite kind of at a gruelingly slow pace you'll start to be able to tolerate more and more normal portions. We'll start to see some weight maintenance. I'd say it probably takes about 2 months to really start to see some of that weight gain and rebuilding of that muscle tissue, being able to get adequate calories and protein. And then in terms of the residual side effects, there can be some lingering ones longer than that. However, for the most part, I'd say people return back to their normal diet after 2 months.
In terms of from the physical therapy and functional mobility side, similar to Tal, for about 4 to 6 weeks, there's activity restrictions that we have in place just to make sure that things are healing correctly and no sort of overexertional activity disrupts any of that healing. So avoiding pushing, pulling heavy things, lifting heavy things. We want patients walking in general, but about 4 to 6 weeks is when we sort of want them to back off a little bit and then gradually reintegrate some activity. And that looks different for different patients depending on what their goals are. Another thing that I answered in the chat is at about the 6-week mark, because there's so much scar tissue that sort of forms at the incision, it feels very tight in the abdomen. And that's something that physical therapy can help with, either teaching a patient how to do self-scar massage or having them come into the clinic and performing it in clinic as well. But it's sort of individualized on how quickly patients can get back to their normal activities post-surgery, but it takes time.
Yeah, I mean, I can comment too. I think they answered it pretty well, but I would agree. I feel like patients most feel more like themselves about 3 to 4 months after surgery when they've got their diet down, they're feeling more active. It also depends upon the surgery that you got. I feel like this is a very individualized surgery, so people have varying levels of recovery. So I always warn people, before you start Googling things, just remember that this is very much individualized. So I feel like it's a good conversation to have with Dr. Mogal when he's talking to you about surgery. Because for instance, if your bowels are involved, you might have some difficulty with just bowel function after surgery, which takes some time to kind of pin down what works best for you and how to make your day-to-day life a little bit more manageable. But I think after 3 to 4 months, people are typically feeling more like themselves and back to normal.
Great. We have one question that I think would be great for Dr. Goff to answer if possible, that is floating through the chat that I can't answer, which is, how soon after surgery is it safe to start hormones? I realize this is not quite your area, but what do you usually recommend for patients who might have their ovaries removed?
It depends on their age to some extent. You know, if people are already postmenopausal, we will sometimes, you know, just wait and see what the symptoms are for patients and maybe hold off until, you know, 6 weeks or so. If people are young, you know, say you've got somebody, you know, in their 20s or 30s and you remove both ovaries, they are going to be symptomatic, very symptomatic within about 48 hours because it takes about that long for the estrogen levels to just plummet down. So usually in those patients, we actually will put a low dose estrogen patch on them so that they don't have severe hot flashes unless there's a contraindication to estrogen, which in most HIPEC cases, there's not going to be a contraindication to low dose estrogen, but we would at least start it there and then would gradually increase it up to control symptoms. But we don't want people to be having severe hot flashes in addition to dealing with all of the issues with recovering from surgery. That just seems a little cruel to do. So, but we have to make sure that they have good DVT prophylaxis or blood clot prophylaxis. And so that they're getting both the massaging boots and they're getting low dose of either Lovenox or heparin or something to make sure that they don't clot, because that is a high risk time for blood clots. And so we have to be very careful about that in the post-operative period.
Thank you. And thank you to all of the panelists and everybody who participated today. As Dr. Mogal alluded to, we are going to have more time at the end for a little bit of Q&A if there's residual questions. We don't expect to be able to answer everybody's questions today, and sometimes it might involve a longer appointment in clinic or something to actually have the full conversation. But I do appreciate everybody who's participated thus far. And now I have the distinct pleasure of introducing a patient of mine that I share with Dr. Mogal, Angie Ballou, who is going to share her experience. And this was a really unique opportunity because when I met Angie, we didn't have our HIPEC clinic actually started yet. And so we went on the journey of starting things together. So Angie, thank you.
Thank you so much. And thank you for having me on here today. I'm going to start by just telling you all a little bit about myself, and then I'll take you through my cancer journey. I am married to my husband, Travis. We've been married for almost 20 years. We have 2 boys, Tanner's 18 and Jake is 14. We live here in Central Oregon. We are from the Washington area, so we lived in Marysville, Washington. That's where we're from. But we moved here in 2019. We love everything outdoors, so we came here on ski trips and fell in love with the area. And we do everything that you can think of outdoors, whether it's skiing, mountain biking, hiking, camping. We love all of those things. So we moved here in 2019. My first bout with cancer was actually in 2017, towards the end of 2016. It was at Thanksgiving dinner. I felt really full and had some pain and discomfort and went to the doctor. And at first everything looked normal, did a CT scan and did see that there was something in my small intestine. And they did a colonoscopy, but they couldn't reach to where that mass was. So then they ended up doing surgery in 2017, and it was cancer, adenocarcinoma in my small intestine. And they removed that tumor, and then also some lymph nodes that were nearby. And in one of the lymph nodes, there was some cancer in there. So I did 6 months of chemotherapy at that time, and everything appeared good. I, of course, had routine scans every 6 months. And then in 2019, everything looked good and was able to go to having scans every year. And then that's when we moved here to Central Oregon in 2019. And so my next scheduled CT scan was in 2020. Of course, that's right when COVID happened. So there's a little bit of a delay there. I think it was a couple months behind on my CT scan, but I had that in May of 2020. And the results were, there was some hazy area in that CT scan. And so the oncologist here said, you know, we could wait a little bit and retest and see, or we would have to do like a laparoscopic surgery to determine what it is. And of course, with my history, I didn't want to wait. I wanted to know what was going on. And so in June of 2020, had a laparoscopic procedure and determined that it was cancer. And this time it had spread to the peritoneal area. So it was stage 4 cancer. The oncologist that we met with here in Central Oregon did not have good news for us. You know, he said that I had maybe 2 to 3 years to live, and that any other types of treatment besides just being on chemotherapy for the rest of my life was very experimental. And, you know, my husband wasn't going to take that for an answer. And so he asked for us to be referred to Seattle Cancer Care. And we met with Dr. Cohen in July of 2020. And, you know, Dr. Cohen said, it's very, very serious what you have, but there's always hope. And we have this procedure, HIPEC. She explained it and said that they are working on getting this program started. And so what she would like to do, though, in the meantime, is get me started on chemotherapy. So what was really awesome was that she worked with our local team here in Central Oregon to allow me to receive treatments here close to home, which was great because then I was still able to work and kind of just have a normal routine, normal life while being, you know, under the guidance of her and Seattle Cancer Care. So we really appreciated that collaboration between Dr. Cohen and the oncologist and the team here in Central Oregon. So, you know, always when you're going through these things, there's always things that come up. I started chemotherapy later that month in July and had a couple of treatments. And in August, I had a severe allergic reaction to the oxaliplatin. And so, of course, Dr. Cohen got with the team here and, you know, restructured the type of treatment that I was going to receive going forward. And so she worked with them to get a little bit of a new regimen going. And all was going well. I, you know, had a couple of blood clots as well. So she worked with the team here. And I mean, everything, even with all of these little hiccups, everything still went so smooth because they worked really, really well together. And then I believe in December of 2020, that's when I met Dr. Mogal. So Dr. Cohen said it's a good time to meet with Dr. Mogal. You've been on chemotherapy now for 4 or 5 months. And that's when I met with Dr. Mogal. And Dr. Mogal explained the HIPEC procedure. And then he wanted to take a look. For me, for whatever reason, I know the CT scans don't show everything. And so Dr. Mogal wanted to see for himself what things looked like on the inside. So he did a laparoscopic surgery in December just to see how things looked. And he said that he thought that the HIPEC procedure would be, I was a good candidate for it. So everything was looking good to proceed with surgery. I had one more chemotherapy treatment after that, and then I needed to stop so that my body could be ready for the HIPEC surgery, which was scheduled to be the first part of February of 2021. And in January, just like what they were talking about here, I met with a physical therapist. I met with Tal about nutrition and just, you know, giving me that path, that surgery, it explains kind of what I'm going to go through, the healing process and all of that. So that was really, really helpful. I felt like, okay, I know the steps and I know what it's going to be like of course, everyone's different and things come up, but it does give you an idea of how things are going to go. I followed their plan, and there's a lot of things that they want you to eat, a lot of protein to get your body ready. I also continued to do as much exercise as I could. Like I said, we're big into skiing. I skied several times that month. I did some snowshoeing just to try to make sure that my physical strength was up for the surgery. The surgery was scheduled for the first part of February, and unfortunately, at first my insurance declined the surgery, but Dr. Mogal, he provided documentation and case studies, and shortly after that, my insurance approved the surgery. So we were good to move forward and had it, I believe, February 11th of 2021, February 12th. And so we headed to Seattle for the surgery. It was, my surgery was, I think, about 12 hours, and removed part of my small intestine, about 10 inches of my colon, my gallbladder, and a complete hysterectomy, and then did the Hypex or the heated chemotherapy treatment after. I would say that it's definitely, that's a long surgery and a lot of recovery. But one thing that I tried to do as soon as they allowed me to get up and walk, I made my laps around the floor that I was on as much as I could, because I wanted to get out of the hospital. I think I was in the hospital for 8 or 9 days. And then my parents live in Everett, Washington. So I stayed with my parents there because Dr. Mogal wanted me to stay in the area before heading back to Central Oregon to make sure that everything was good. I didn't really have any complications with the surgery. Of course, like I said, it's tough, getting up and motivating yourself to walk and get your strength back. But definitely have a supportive family, and they would, tell me it's time to get up and do your laps. So I would, walk my laps around my parents' house, and I had routine visits with my team there at Seattle Cancer Care, and with the nutritionist, making sure, there were some tweaks that we made in the beginning when, it seemed like maybe I couldn't eat certain things and all of that. They helped me with my diet. And after a few weeks, Dr. Mogal cleared me to come back home here to Oregon. So, once I got back home, I would take walks in our cul-de-sac, and then I would eventually, get up to walking around the block. My goal was to be back at work in 6 weeks. Dr. Mogal thought maybe that was a little bit aggressive on my part to try to be back to work at 6 weeks, but I'm a bank branch manager and I have a laptop. I can work from home some, so I don't have a super physical job. And 6 weeks to the date of having my surgery, I was back at work. And I have a great place where I work at, and they were very accommodating. If I was tired one day or whatever, I can leave and, rest up and all that. But I would say that after about 2 to 3 months, I definitely felt a lot more like myself. I skied 12 days this past winter, so downhill skiing. I did 12 days of that. We hike a lot around this area. It's sunny here a lot. And mountain biking, did a lot of that last summer as well. So I can't thank the team enough at Seattle Cancer Care, Dr. Cohen, Dr. Mogal, and all of the team there for all of their, the way that they have things mapped out, the appointments with the physical therapist, with the nutritionist, with them and their team. It's very helpful. If I had questions like before surgery about anything, I could call and someone would answer. And it works out really, really well with how they do things. And I love how they coordinate also with the oncologist here in Central Oregon, because that allowed me to have somewhat of a normal routine with my family. And yeah, so I feel great. And like I said, this team is a great team to work with. So I hope that helps. And if you have any questions, let me know.
Thanks so much, Angie. I think one of the key takeaways, obviously, is that every patient that has peritoneal disease, whether it's appendix or colon or other types of cancer, is unique in their own way. Even though we strive to move everyone through their different treatments in a certain way, every individual recovers in their own time. Every individual has different or unique needs. And I think the best part about the team that we get to work with is that everybody is in tune with those needs for the patient. So we give patients the time and the space they need to recover, and the resources as best as possible that we can provide them to recover. So thanks so much for sharing your story, Angie. And I wanted to introduce our next patient speaker, Troy. Troy came to us with a diagnosis of colon cancer with peritoneal carcinomatosis, and got treated similar to Angie, both closer to home as well as with us at SCCA and UW. And Troy, if you want to go ahead and share a little bit of your experience, that would be wonderful.
Well, thank you very much. The video won't start, but you don't need to see me, I guess. First off, if there's ever a description of what holistic and organized medicine is, it is the Seattle Cancer Care Alliance. Everything is mapped out to the T. And for a person that has a production management background and kind of an engineering background, that is absolutely brilliant. So thank you to everybody, Dr. Cohen, Dr. Mogal, Tal, Jenica, everybody. Allyssa that answers the calls. Thank you so much. You've given me the opportunity to live a longer life. So I appreciate that. So thank you very much. I live in Yakima, Washington with my wife. We have a 22-year-old son. Similar to Angela, I'm a rabid snow skier. That's all I like to do, outdoors type, love to read. In March of 2021, I noticed I had some pain in my abdomen. But before that, I took a Cologuard test and it came up positive. I went and saw a GI doc, and the GI doc said, well, you're only 51, so 52. Statistically, you would be so rare for you to have any type of cancer. Don't worry about it. We'll schedule the colonoscopy for 3 or 4 months. Just don't worry about it. The thing about statistics is that, yeah, it might be a remote possibility until it happens to you. And then statistically, it's 100%. And so off we go. April 23rd, I got the news from my primary care physician that I had the adenocarcinoma, the omental caking. And that's where it started. And the first thing out of his mouth was, we're going to get you SCCA. And that's how it started. I took chemo in Yakima, Washington, where I live, under a local oncologist, similar to Angela, and Dr. Cohen and Dr. Mogal both coordinated all that. That was absolutely brilliant because the place I took my chemo was only just down the street, basically. So it was really nice not having to come to Seattle. I took 10 rounds of chemo. October of 21 was my last round of chemo to prepare me for surgery. I went into surgery on November 19th, had a 15-hour surgery. Dr. Mogal said that I was a candidate for the cytoreduction and the HIPEC, but it wasn't going to be a slam dunk. And so we went into that thinking that, but nevertheless, just pressed forward. I would recommend, Dr. Cohen said, Dr. Mogal said, we recommend that you take the epidural. And I would say that it should be a stronger advice than that. I would tell any patient, if they can handle it, to take the epidural. that absolutely helped me, no question, on my recovery in the hospital, being able to get up, walk around, and being able to just have a quality of life in the hospital and allow you to sleep and heal. The care map that I found was really just brilliant. I was able to put that in my phone and check off every part of what was required. So that was absolutely incredible. Post-surgery, I walked around. I tried to walk. The first day I was out of surgery, I didn't walk that far, but days 2 and 3, I started hitting about a mile, and I just kept walking all the time. I just did not stop. And I felt that helped so much because it helped my body. It helped me relax. It helped all my muscles to become active again. It gave me a sense of purpose, actually, while I was there. One thing about being in the hospital, one thing that maybe doctors are not thinking about from the patient's perspective is I got a pill stuck in my throat when I was taking a painkiller. And it was horrible. I mean, I had a tube down my throat. And of course, you can't take any real water in. So I had a pill stuck there for a couple of days. But the staff was really flexible. The pharmacy was flexible enough to give me liquid medication. And so that really helped. So that would be another recommendation to patients if they can't swallow with a tube and take pills, would be to take liquid medicine. And then of course I have a port, so my port was accessed, and that made it a lot easier as well. That's about all I can think of right now. I do remember that Dr. Mogal said, and Dr. Cohen both said that we can beat this, but we can win, because I asked him directly if we can win it. And Dr. Mogal said, yes, we can win, but it's going to be a marathon. And I told him, well, I'm okay with a marathon. I just want to know, I'll work as hard as I can to get this done. And Dr. Cohen said, well, yeah, it's a marathon. And yeah, we can win it, but I'm not here to win. I'm here to cure you. And I just liked that confidence. That's what I needed in that situation, because I'm very confident and very sure individual. So I felt that I had two partners there that were like, yeah, I'm going to meet that. We're going to work as hard as you are. So thank you very much for that. We stayed in the I think it's called the Collegiana Hotel or long-term. Allyssa, maybe you know what that name is, but it was long-term care, a lower cost term care where you can do your own cooking and everything. And my wife, Kim, was with me every step of the way, making sure that I was fed. And two things always come out of her mouth is, you need to eat, you need to walk. And that was about all that she said, other than other things. Have you eaten enough? It's time to walk. And I did. And I was able to leave and come back to Yakima much earlier than I even anticipated. And then when I got home, I just kept my physical activity up, just walking as much as I could. It was kind of cold, but I did the best I could. And then before my surgery, I committed to a 2-mile walking regimen every single day. And I think that really helped. And I did some physical therapy, strengthening exercises until the chemotherapy until my body just got so wore down, I just couldn't do physical therapy anymore. The mindset I had going into the surgery was one of, like I said, winning, but just stealing my mind that this is the only chance I have at long-term survival. So, I'm going to pull the parachute ripcord and we're going to float down to the ground. I mean, you have to have that mindset. And that's what I just committed myself to. I think that's about it. I will say I'm a Google freak. I love to Google stuff. And so I only had to do one Google search and see that medical information is very contextual. So I just committed to not Googling at all. I didn't Google anything after that, nothing, zero. So that really helped me, because I'll Google and go down rabbit holes and read studies, and that's not helpful, not helpful at all. Doesn't do anything, didn't do anything for me but worry me. So anyway, that's it. That's what I would say.
Thank you, Troy. That was very nice of you, both Troy and Angela, for sharing your stories. Again, I encourage everybody to think of this in terms of their own personalized plans. our aim in our HIPEC multi-D clinics is not to roll a rosy sort of paint a rosy picture about your diagnosis, because obviously this diagnosis is devastating for most patients, especially when they have very little information when they've come to us. But it's truly to provide you that realistic understanding of where you are in your cancer diagnosis, the gamut of options that we have, in terms of the tools that we can employ to treat you, whether it's to control your disease, whether it's to potentially provide long-term disease control and cure even. But we will always be honest and realistic about it. And at the same time, make sure that that hope that you have in terms of being able to overcome this will always be alive. So I think with that, I will hand it off to Meredith so she can introduce a couple of our other guest speakers today that we're all excited about.
Yeah, thank you, Dr. Mogal. We're really grateful to be able to collaborate with two organizations for today's presentation, AC PMP Research Foundation and PMP PALS. And first, I'd like to introduce to you James Carroll, who is the president of AC PMP Research Foundation, and he's going to share some really great information with you. So, James, let me know if you're able to share your screen and take it away.
Let me attempt to do that. Can you see it?
Not yet. And if you're having trouble, I can share. I'll let you try one more time, but if not, I can open up the presentation and share from my desktop.
Try one more time. Any luck?
Yes, but if you can go up to the display settings and switch over up in the upper left-hand corner, because we can see your screen, the presenter slide. And if you switch over, no, yep, right there, duplicate, swap that, yep, select that one.
Okay. Good to go?
Oh, that didn't quite work, but if you, why don't you take it out of slideshow mode and maybe just share your screen with just the slides, because your computer doesn't want to share with us the presentation mode.
Okay. Last try.
Oh, that's working. Perfect. Beautiful.
Okay. Okay. Terrific. Well, thank you very much. It's a pleasure and an honor to be here and participate today and share a little bit about my story and the story of the foundation. And I would start by saying that my journey began back in 2004 when my best friend Dutch was diagnosed with appendix cancer. And at the time that he was diagnosed, the landscape was very, very different. There was hardly any information available. Things like HIPEC were in experimental stages. And it was just a very challenging period in order to have the disease and fight the disease. And, at the time, PMP PALS was probably the single only resource that was helping patients and doing a great job at it. Well, my friend had a courageous 2-year battle and ultimately passed away. And after he passed away, his wife Judy and I got together and we decided we wanted to try to do something to help people that came behind us. And we started to, we held a fundraising walk, and we decided that we were going to start our own foundation. And we raised some money, and only to find out that there was really no place good to donate to that was doing anything relevant to research and education. So as a result of that, luckily, shortly thereafter, the ACPMP Research Foundation was actually formed by Lisa Luciano, Mike Dvorsky, Jerry Lewandowski, and a small group of individuals. And we were fortunate enough that we could do an initial contribution, and subsequently Judy and I had joined the board, and we have been involved ever since. Let me try to, okay, hopefully we're on slide 2.
Yes, looks great.
Okay, so we are a 501c3 organization, and the visual tells really the brief story that we are here to attempt to fundraise in order to fund research, fund education, and eventually try to find a cure and really impact the quality of what's going on with patients. So in its simplest form, that's what we're here to do, and that's what we've been doing really since inception. The current board, I have actually been with the board since about 2009. I became president within the last 2 weeks when 2 very dedicated individuals, Jerry Lewandowski and Susan Ortega, after long contribution to the foundation, have stepped down. So we recently went through a reorganization. I'm the president, Judy Culbertson is vice president, and Judy and I's focus is really fundraising and education. And Deb Shelton is the vice president, and she's really in charge of the scientific arm relevant to research and education. And she's got tremendous knowledge and has had tremendous impact since joining us. Heather is our staff assistant who joined us about 9 months ago. She's a survivor, diagnosed in 2014, and she's doing some great things for us as well. We had the benefit of an outstanding medical advisory board, and it's really a mix of ACP&P specialists that include surgical oncology, medical oncology, pathology, and really some prolific researchers. So many of these have been with us for a number of years, and they've helped guide our activity and point us in the right direction relevant to all the medical aspects of what we're trying to accomplish. From a research approach, we always have been trying to fund meaningful research, and we have been from the very beginning tied with the National Organization of Rare Diseases, and basically we fund through them, and they have a rigorous process of putting out RFP submissions, and they actually score all of this the submissions and determine who the winners of those grants would be. And we've averaged probably 2 to 3 grants for $50,000 each for the majority of the years that we're here, that we've been in existence. So we've been able to fund some tremendous research over the years. If you look at the breakdown on this slide, you'll see that we're currently over $1.5 million since that time period. Over $1 million has been in the United States with 22 grants. And we've actually done a fair amount, 10 grants of international, which speaks to the quality of some of the international researchers and doctors that are involved with appendix cancer and PMP. The other thing that we've really tried to focus on was education. And, you know, at the time, as I said, in the early days, we saw the good work that PALS was doing. And the area that we really tried to focus on that we thought was a gap was, number one, research. And the second part was education. And the education has really 2 goals. The first part of the education that we're going after is medical education, because we noticed that many of the patients were always being misdiagnosed in the beginning. And oftentimes when they were misdiagnosed, it took a period of time before they could get to the true specialists that understood the disease. So we intentionally did these symposiums mostly to try to expand the expertise within the medical community, educate doctors so they could subsequently know about the disease and get to the specialist quicker for proper treatment plans. The other part of it has always been obviously patient education. So we continue to do events like today. We did an event with Wake Forest Huntsman's and the Institute and University of Chicago last year in the fall. And we're currently in the early planning stages of trying to do that event again this year. The other thing that we do is we sponsor physician scholarships, and that's very similar. You would think, well, why physician scholarships? We are trying to bring more people that don't have expertise in appendix cancer to some of these appendix cancer and PMP related symposiums, so we can broaden the expertise and really try to continue to grow and develop a broader base of physicians that have expertise in the ability to treat patients. So how do we support our initiatives and programs? You know, it's fundraising. I mean, fundraising is an important part of what we do. And, you know, it started, as I said, with a walk that we held in memory of my friend Dutch. And then basically what we've done is we've created a platform that people can contribute to our organization. And if someone wants to step up on a volunteer basis, regardless of what it is, it's a bake sale, it's a walk, it's a 5K, it's a bar crawl, then we assist them in trying to guide them through it. And oftentimes we would customize a website for them that allowed them to take registrations, take in revenue that goes directly to us, and we help them manage their fund through our platform. So it's a whole diverse group, and it's really been reliant on tremendous volunteers that have been impacted from the ACP&P community. If you look at our website, we've got tremendous helpful resources there. We've got links to online support forums. We've got patient support organizations and a variety of patient education resources, video library, facts, and we have a fair amount of fact sheets that are printable, informational, that are from our organization, new patient guides, our brochure, things along those lines. So tremendous resources for someone newly diagnosed. And we really support a variety of patient empowerment issues. And this is some of the area where we focus and hope to grow. We have a new patient guide that provides some resources. We try to monitor and track all of the current clinical trials. So if someone goes on, they can find out that information easily. A new initiative of ours that we're excited about is a patient registry. And we've been working on it in collaboration with NORD. And we're just about ready to launch and get it started. And it's going to allow patients to basically sign up, register, contribute information in an anonymous fashion that hopefully will benefit the physicians in being able to evaluate research, et cetera. And patients will have, it's free, it's voluntary. And if any patients choose to get involved, they can join. And if they no longer want to be involved, they can withdraw at any time. Missed the slide. Thought I had a slide for volunteerism. I would just put a plug in that volunteers are the lifeblood of our organization, and it's a great way to give back. And so many times I remember when Dutch was sick, people said, what can we do? And I think oftentimes for family and others, the answer is that you can help out in some solid particular way. And we have great opportunities with the foundation if anybody wants to step up and do that. In closing, I would say that, first of all, to the Seattle Cancer Care Alliance and the physicians today, we thank you for your leadership and support, and we ask for your ongoing support and participation. To Adele and the PMP PALS organization, who you're about to hear from, thank you for your continued outstanding work and support of the patient community for a long time. We believe that collaboration within the organizations is critical and important. To the patients and caregivers, I would say, know that you're not alone, that there are others here to help and support you, and know that we, the ACPMP Research Foundation, are here to support you. And we invite you and your family members to join us and support us in the fight. Know that progress is being made and that there continues to be great survivor success stories. And lastly, stay strong, never give up. And I thank you for providing us the time today.
Thank you so much, James. That was a really wonderful, informative presentation, and it was great to see all the work that your organization is doing. I would encourage you to share some of those links in the chat so that our attendees can access those links. And now I would like to, you provided a great transition for me. I would like to introduce Adele Jason. Please correct my pronunciation of your last name if I got it wrong. Adele is the Vice President of PMP PALS. So Adele, I'd like to turn the mic over to you. And if you have slides to share, please do so.
Thanks so much, Meredith. I had the same crazy thing show up as Jim did. So if you have my slides, that might be easier to.
I do. Let me go ahead and get those up for you.
All right. It is PM PAL's pleasure to be here and to be associated with this event. So our heartfelt thanks to all of the presenters today, and echo Jim's comments. Along with ACPMP, we're here to support the patient community and to make things better for all of us caregivers and patients.
Okay, is this, are you seeing the correct screen that you need?
Yes.
Okay, you just let me know when you want me to advance the slides.
Okay, so PMP PALS is the world's oldest global volunteer-run organization that gives hope to patients and caregivers fighting appendix cancer and PMP. Our organization was started by our founder, Gabriella Graham, in 1998. And really, Gabriella paved the way for so many of us. She provided support, education, and really made things better for those that followed. She passed away in 2014, and so many of us patients that benefited from her efforts were continuing her legacy. One of the things I will say is we've talked a lot about the physical journey during this presentation, and we often say at PMP PALS, the emotional journey is just as important. The emotional resilience of this, as patients, caregivers, medical team, you have your ups and downs, and so that is our focus. We have a variety of programs, next slide, that I really would like to just review with you today. One of our most popular programs, and this was a result of COVID times, we had in-person meetups, and COVID changed that. And so now we have Hope Zoom calls. And these are patient support calls that we have twice a week, Saturdays at 11 a.m. Eastern, 8 a.m. Pacific, Thursdays, 6 p.m. Eastern and 3 p.m. Pacific. These are opportunities for everyone to jump on and tell your story, and the power that comes from patients and caregivers, being together is just incredible. It's just has become a support system for all those that participate, and we learn from each other. And we do have special physician presentations and other educational sessions, from time to time too. But encourage those of you, everyone here today, to please join us when you can. Another thing that we like to do is to send people starter kits. So you get your own PMP PALS bag with just practical little items to help you either before surgery, after surgery, and in your daily life. One of our most popular programs, and this was a program that Gabriella had started, is our Get Well Card program. And it's really more than Get Well cards. It's cards anytime you need support. And there's nothing more overwhelming in a good way than getting cards from patients and caregivers around the world to show that you're not alone and that you are supported. And those of us that were lucky enough to receive cards, we still have them. And we're all about providing hope and support. And so knowing that you're not alone. So we encourage you to ask us if you'd like to be on the card list. And even if you don't ask us, if we know about you, we get you on our list. Next slide. Another legacy program that Gabriella had started, and this was actually the relative of another patient, is our Bare Bottom Bears program. You also get your little bear, a little friend, to come to you when you're going to surgery or you're just having a down day. You can look at your little bear and again know that we're with you in terms of support. Mentorship has been a long time program of ours. We also provide, one-on-one connections between patients, and with our Hope Zoom, this has been really a natural outgrowth of people making those connections. And so we have our group support calls, but also a lot of one-on-one contact. We also have a feature called Ask Arthur. Arthur is a retired surgeon, pediatric surgeon, but also a patient. And so he volunteers his time by responding to more clinical medical questions. And we're grateful for the time that Arthur provides us. You can reach us at any time, info@pmppals.net. Don't hesitate to reach out, ask us a question, really about anything, and we'll connect you with something or someone or help in any way. We're on social media, Facebook and Instagram. Our website, we have a lot of information on our website relative to preparing for surgery, patient stories, what we can do. And so we encourage you to visit our website. And in summary, really what we do is support. So we connect patients and caregivers during what is a very, very critical time for us. I meant to mention my story. So I'm lucky enough to be a little over 10 years out from my CRS HIPEC, and it's every day is a celebration. And we're with people when they're newly diagnosed. We're with people as they continue on their journey. As I mentioned, we're totally volunteer run, so please check out our website. And we're always looking for volunteers or any financial support you can provide us. And lastly, again, we have hope for you. This was Gabriella's tagline, and this is what we provide. We are here for you in the here and now. We're with you every step of the way during the patient and caregiver journey. And we'd encourage you to interact with us and stay in touch with us. Dr. Mogal has been a friend of PMP Pals for a number of years, so we're happy to have that connection, and we're excited about being here as a sponsor today. This was very, very informative, and as Jim from ACPMP said, we're here to fight the good fight with everyone, and hopefully those coming after us will continue to benefit from all of the research and the efforts that everyone provides. So again, thank you for allowing us this opportunity to tell you about PMP Pals.
Thank you so much. That was really wonderful. So now we have time in our agenda for our panelists to answer questions from our guests today and our attendees today. And so I know there's been several questions posted in the chat. And so Dr. Mogal and Dr. Cohen, I'll let you two moderate. Also, I wanted to note that I will be sharing some links in the chat. I'll be sharing links to the recording. It's been posted a couple of times, but I want to post it again to make sure everyone sees it, and I'll also be posting a link to a survey because we would love your feedback about your experience attending this webinar today. So thank you.
Thanks, Meredith. Dr. Cohen, as you noted, a lot of patients have been very curious to understand the role of ctDNA. Could you kind of clarify the role, at least in terms of standard of care for both colon and appendix patients, and and which patients do you select in your consultations with patients to actually use this modality for either surveillance, for recurrence, or other, treatment response?
Yeah, and thank you everyone to their interest. I know that this is kind of one of those topics that comes up a lot when you are in patient communities, when you're Googling, when you're paying attention to sort of what might be cutting edge. The reality is that circulating tumor DNA or ctDNA is not standard of care. And a lot of providers, if you ask them, even say, here's how you order the test, they might say no. And I definitely had patients come to me and say, look, my provider doesn't want to order the test. And I say, that's okay. And the reason why I say that is no provider should ever really order a test that they don't understand the interpretation of. And there's a lot of nuances to ctDNA that I have learned over the years, being somebody that's ordering it, that's researching it. And so if you don't understand all of that, I am very supportive of providers declining to order the test. That being said, if you go to a larger center, if you're starting at a community practice, let's say you go to a larger center, they may have more familiarity with it and may be willing to do that. So I definitely have patients that I follow that I see intermittently and basically just order their ctDNA and they get a lot of their other care at their local practice. So know that there's options to still get the test if you, as an informed patient, really feel like it's the right thing for your care, but your provider is not somebody that has the comfort level at this point. So other things to know is that because it's not standard of care, you have to find a situation where the company is basically going to pay for it for the most part, because we don't want you to be racking up large out-of-pocket expenses for something that we don't know is standard, don't know should really be done. And so again, you want a provider that understands how to do all of that. But to get to the bigger question of who am I doing this on, I am often ordering this for patients who I think have been definitively treated with surgery. So that largely in my clinical practice is colorectal cancer, appendix cancer, but we may think about this for really multiple other cancer types that aren't even necessarily even GI cancers. So there's a lot of different avenues for this, but it's really one of those fields that's ballooning up right now. But like any new technology, you have to understand it before you just jump on board and use it. Because once you get the result, we want to be able to interpret it and say, based on this result, here's what we think. And if we don't really know that answer, then we have to be careful about ordering the test outside of a study. So I encourage you, if there's a clinical trial opportunity, to definitely participate, because that's the way that we learn. But outside of that, we're going to be using it in clinical practice in a limited way. A limitation is that peritoneal disease, which is our topic of today, may be missed by ctDNA. So again, there are some benefits to the test, there are some limitations, and so part of ordering it and understanding it is knowing what you're getting. And so I would encourage you to have that discussion with your provider, to look at other centers if your provider is not comfortable with the test. And really, at the end of the day, it's never necessarily the right thing to do, but it could be selected if you have someone who agrees that that's right for your particular case.
Thanks, Dr. Cohen. You bring up several very important points, especially that we don't have much information about ctDNA. We don't know how to interpret the test in the post-operative setting. For example, if patients have a positive ctDNA result, say 3 months after surgery, but their scans don't show anything, their tumor markers are normal, how do we, for example, go about intervening on that? Do we treat them till their ctDNA becomes negative? Or do we continue watching till something else shows up, or try to find other modalities to diagnose other sites of metastatic disease that may not be visible on standard CT, for example, do a PET to figure out the cause of this rising ctDNA? I think there are just a lot of unknown questions, and I agree that having these tests done by providers who not only have utilized it before, but can sort of frame it in the general discussion based on the advantages and the disadvantages, and when to really focus on it versus when to say, we can't really look at it in isolation. We have to look at it in the grand scheme of things, is important.
Yeah, I agree with that. It's really meant to be additive to the global care. I don't make decisions on ctDNA alone. It's always in the context of the cancer, the scans, the chemotherapy, the CEA, and specifically for that patient, what are reliable markers, what aren't. So again, these are never sort of black and white test results. They are additive, and it is the whole clinical picture that we use to guide care.
Great. Another question that came up quite often in the chat was regarding the differences or advantages of EPIC versus HIPEC. And I think we did try to address some of this, but the bottom line is there are no good head-to-head comparisons between the two. There are retrospective studies that show advantages and disadvantages of both approaches. The advantages of HIPEC is it's sort of a one-stop shop. So we can administer the treatment at the time of a patient's operation without majorly adding to their complication rates. And we can also exploit the heat, the cytotoxicity that heat can itself promote during surgery, which we can't do with EPIC. The problem with EPIC is that the process of treating patients is a little bit more involved, because we have to place special catheters that stay in the abdomen after surgery and instill chemotherapy after surgery on a scheduled basis. Many people who do CRS HIPEC know from having gone back in patients' abdomens, say a week or 2 or 3 or 4 weeks after surgery, that the process of forming adhesions or scars starts very early on. And when we have catheters placed in the abdomen, because scar tissue forms around the catheters, the efficacy of the chemotherapy solution in distributing evenly throughout the abdomen may not be as great. And a lot of factors determine that, what was the extent of the multi-organ resection, what was the extent of the peritonectomy, because a lot of that will basically determine how robust and how extensive the scar is going to form in the early postoperative period. And therefore, I think it's hard to compare the two modalities because it's not comparing apples to apples. And I think there's no data that shows advantages of one over the other. Certainly in our practice, we don't tend to employ EPIC because, again, there's no data to really support that it has its specific advantages in, say, appendix or colon cancer compared to HIPEC.
Thank you. Another question that had come up a couple of times, which might be worth addressing, is second HIPEC surgery. So Dr. Mogal, do you ever recommend that a patient who had HIPEC once and maybe had a recurrence a year or two later, would you ever recommend that they have a HIPEC surgery again?
Yeah, thank you for that question. I think that's a really important one to answer. I think, again, whether patients receive a second or iterative HIPEC operation depends on multiple factors. One is, what was the original histology or pathology for which HIPEC was offered? Two is, what is their general sense of their disease biology or course? For example, is there a fair amount of time between their first surgery and the time they had recurrence, at which point you can say that their disease was relatively slow growing and HIPEC may help. For patients who have a disease-free interval, and we use this cutoff somewhat arbitrarily, so it's not a line set in sand, but for patients who have recurred less than a year after their initial treatments, it's very challenging to justify redoing a HIPEC, especially that if their recurrence has been that fast, we know that the advantages of doing these local regional therapies may not be as good. But for someone, for example, with lower grade disease who has had a fair amount of time that's disease-free, has recovered fully from their operation, and we're basically attempting to quote unquote set back the clock, offering them a repeat cytoreduction HIPEC may be beneficial. So I would say the decisions are fairly nuanced in individual patients. Sometimes, for example, we have low-grade patients who have their surgeries, are disease-free for a long period of time, and then their disease picks up pace. We don't quite know why, because mutations generally don't change, but somehow their biology changes in terms of the aggressiveness of their tumor. So in those situations, sometimes we will employ chemotherapy prior to deciding if patients are candidate for surgeries, and only then provide them a second HIPEC. I will say though, by and large in colon cancer, the data for iterative HIPEX is unfortunately not that robust, partly because they tend to be more aggressive, and partly because the patients tend to, if they do recur, they tend to recur within the first couple of years. And so putting them through another operation that may not necessarily provide that much benefit is challenging. But there is a need, or rather there is a place for every patient in evaluating whether they're going to be a candidate for a second CRS HIPEC, and I think that has to be done within a multidisciplinary setting.
Thank you. I think those are the major topics that had come up in the chat. We understand that a lot of people on this education event may have really specific questions, and again, we do our best to try to answer these in generalities for the purposes of this ed event for all, but it really is a very individualized type of treatment for a person's location of their cancer, for their other medical issues, for their past treatments. And so we encourage you to talk to your local teams, to ask for a consultation to a center like ours. If you feel like you might be a candidate for something that you're not having access to locally, and just keep the conversation open, be in touch with the patient support groups, and just really, I think it's a good disease to communicate about, because as has been described in numerous ways, not everybody knows about it.
Thank you, Dr. Cohen. Again, I echo Dr. Cohen's sentiments. Please reach out if you have questions. We hope to continue doing this event, and hopefully next year even in person, where you can have all your questions answered. We'd love to learn from you through the survey about which topics you have more interest in learning on, which topics you benefited from, what we can do to improve the event year after year. And before I forget, I need to, call a big shout out to some of our members here who are on the panel, Ritu, Meredith, and Cody, who have been instrumental in helping us put this event together, gathering the necessary resources, ensuring that all our patients are sent out the invitation on time, and just coordinating this event virtually in such a seamless fashion. So thank you so much to you for organizing and helping us get this event off the ground.
It was really our pleasure, Dr. Mogal. Thanks so much for letting us be a part of it. It was a really wonderful event, and it was wonderful to see such a great turnout today. And all the panelists did an excellent job of sharing information. And please, to everybody on the event, please don't hesitate to go up to our link to complete the survey. We'd really like to hear all of your feedback. We have a link where the video will be posted when it's ready. It does take a week or so to edit and get it processed and up on our website. So look for that there in another week or so. I'm also going to share with you my screen one last time. Sorry, I don't have it in presentation mode, but I just wanted to make sure that you guys all have this email address. That's the email address to our team. If you have any specific follow-up questions that we weren't able to answer this morning, please don't hesitate to email us at this email address, and we'll be happy to answer questions as we are able, or forward those questions to other folks.
Thanks, Meredith. One last request. If those of you on the panel and on the screen can put your cameras on for a quick minute so we can take a group picture, that would be incredible. Okay, here we go. All right. Uh-oh, Adele just joined.
I know,
Hold
I was
on.
late, sorry.
Okay, great. Thank you so much, everyone, for joining and for making this event possible. We look forward to your feedback and seeing everyone and more next year.
Thank you.
Bye, everyone. Thank you.
Bye.